So good morning, everyone. We will call our ACIMM meeting to order. Hopefully everyone had a wonderful evening last night. I know we had a little homework assignment to do, but hopefully you still had a moment to enjoy dinner, maybe get out a little bit. The weather was beautiful last night. So hopefully everybody had a chance to do some of that. Just as a quick update, I have spoken with Michelle this morning. So the paper that's on your desk, the envelope for the members, she's going to email this to us with a deadline for when it's due, and then we will email this document and our receipts back to her. So you don't have to worry about trying to fill them out by the break, because that's when she was going to come and get them. So I think yesterday went well. We had a lot going on. It was really good discussion and great presentations. It was really nice to get the federal updates from both Caroline and from Michael, so that we can get more information. It was really good to hear from the Department of Agriculture. We feel like we get to hear from Dr. Warren frequently, but it's always nice to get those updates as we all wait to receive them. We also spent some time, going back to our most recent recommendations to the Secretary, those 59 recommendations, and several were able to share some work they were doing to continue to elevate them, continue to move those things forward. And we want to keep that on our agenda as a way of just following our recommendations. So once we make the recommendations, that's a good way for us to kind of keep up with what is happening with them. And then we spent a good part of the morning really diving into social determinants of health in general, but then we specifically focused on housing. And I felt like we had good conversation there, lots of good information around, are there ways to make some priorities around pregnant individuals and their children, or, are there ways to make sure people are clear on their rights? Are there ways that you can support the landlords themselves? So I felt like it was really good conversation, good discussion, and hopefully you all felt the same way. And then we kicked off right after lunch with our community voices discussion. So it was good to have both Taylor and Drina join us to share their personal experience, but also their experience working with the 2 infant catalyst programs and their focus on housing. And then we were fortunate to have Lachelle Stewart come in with us. Lachelle was able to share specifically around the Baltimore Healthy Start program and the work that is going there. And then we had both Ada as well as Mia to share with us about the Federal Healthy Start program. And we have really good information on the data. So hopefully as members, you all now have a better vision for what Healthy Start is, and you know exactly what it does and has the potential to do in communities around the state. Around the country. And then we moved into our discussion on priorities. And as I shared yesterday, I had good individual conversations with all of the appointed members, not the ex officios yet, though there's still time, but with all of the appointed members, able to just talk to you one-on-one around where do you think we should go next as a committee? We know we're expecting some new members to come on later at the end of the year. And so right now we have around 10 or so members, and that's important for us to keep that as realizing what our capacity is to move work forward. But yesterday I shared with you all of those 12 priority areas. There's a lot going on with those 12. And so last night, one of our requests of everyone was to just take a moment, review a couple of things. One, review of the guidelines that have come out around the maternal health blueprint and what is already in motion, or at least the potential to be in motion. There was a good article around some of the data related to stillbirths. And then there was also the recommendations from the last couple of ACIMM groups. And so it was good to see where we are aligned with them, but also where we're trying to move forward and what some of that potential was. I did take some time last night based on reviewing those areas, and I narrowed down, and I'm saying I, because it was just me in the room doing it. I narrowed down the focus from the 12 and dropped it down to less than 12. And I would like to start the conversation this morning with sharing how I narrowed it down, because I really want to get your feedback into it. I don't think we by any means want to keep 12 priority areas. So we've got to bring this down. But I think part of the conversation will have to be around for those areas for work is already in progress, I think what will be helpful to the committee, so you all correct me if I'm wrong, what will be helpful to the committee will be really understanding what's the status of those other recommendations and keeping that as an agenda item for us moving forward. So right now on our agenda, we really look at those recommendations that were made, the 59 around Alaska, Native American Indian, those recommendations. But if we go back a little bit further and look at even recommendations that were made in 2021, there were some very clear recommendations there around the workforce and diversifying the workforce. There were recommendations there around community health workers and doulas. And do we need to make it as a recommendation again, or do we just need a status report on those? So I want to share some of that. So I don't know, Emma, if you can pull up the slides that I mentioned earlier today. And this is a starting point, okay? Just to kind of get us back focused this morning. And if you go to one more, okay. So I started narrowing them down last night. One of the priority areas that I narrowed it down to was those impactful opportunities, because I did feel like from the conversations yesterday that there was much discussion around, so what actually is working? You know, are there areas of the country, are there communities around our country where they're seeing really good improvements in their maternal and infant outcomes, as well as their associated disparities? So do we need an opportunity to make sure we're looking at the best promising practices or those evidence-based, and what isn't going on? You know, where are there opportunities for spread? So that was one of the areas I looked at last night around prioritizing it. Another area that where it didn't appear that we've done as much work more recently is around systems of care support, especially for rural communities. So there's been a lot of conversations as we are thinking about what is happening in our country, but there's some special areas around rural communities. We're seeing labor and delivery hospital closures. We're seeing challenges with levels of care, depending on where you are. We're seeing desert issues, so, you know, access to care issues. And and there are different care models that are being implemented around the country. The third area that's listed here is more around the social determinants of health or social drivers. And Andre did a great job yesterday kind of laying out for us kind of what the priorities are that are coming out of his team and his programs. But is there an opportunity for us to really narrow our focus on some of those? Because again, he shared the April 2022 report from HHS, but are there opportunities there looking at Medicaid waivers and some other areas to really delve deeper into social determinants or social drivers? And then one more slide, please. And then the other area, the fourth area, was around the impact of pregnancy intentions. And, you know, what is the systems going to be? How are we going to measure it? How will it impact individuals? And again, how are we going to know the impact of the changes that are being made? So those are kind of the four areas that I went from 12 down to 4, but I know that's a big jump. So I want to open it up now for everyone to kind of give your thoughts, your feedback. What did I leave out that you thought, oh no, it has to be on the table for consideration? So I'm going to be quiet a moment and let you all kind of think about that.
May I make a suggestion that we go point by point and just discuss strengths, weaknesses, opportunities?
Sure.
Okay, thank you.
Can you take the slide, go back one slide? And again, keep in mind, I did not include all of the 12, so this has narrowed it down. So if there were part of the 12 or beyond that you feel like should be included, then we can always revisit those as well. So this is the first one around impactful opportunities, and we can call it, that was just a name, so we can call it whatever, but basically what is working? What is working that we have an opportunity to look at, to invite those individuals to share with us what is working, what is their data saying, what is their community saying, and are there opportunities for spread?
Thank you, Belinda. I see some positives here because there are so many good pockets of work being done all throughout the country. And it would be helpful to see what kind of innovations are working for particular community types. I could envision that if we were to use this as an umbrella, then we could break down further to include concepts of social determinants of health. Are there specific populations that respond best to these interventions? And what would the likelihood be of expanding and scaling that? I could also envision with getting examples from different communities across the country, potentially identifying if there are already works in progress that might create some synergy to amplify what's happening. So those are some of the positive aspects that I see with that first point. I'd like to hear what the other committee members may think.
Yeah, I briefly skimmed the recommendations, and there was one, it was around 2013, 14 about redeploying best strategies. And so I think that would be a starting point. I think that might be a starting point as the background for this bullet. I think also, as Marie was saying, we could even break it down to look at, do some interventions work better in urban settings as opposed to rural settings, that kind of thing. Interestingly, of the 4 that you mentioned, 2 were on my list, so I don't know, like mines, but I think that that's a good one too. We've invested, Healthy Start and a number of agencies have invested in a lot of interventions, and I think it's been 10 years since that recommendation to look at and redeploy. So I think this would be an appropriate time to see where we are and where are we getting the best return on our investment in terms of outcomes that we're looking for. While I'm at it, I would ask a 4th one to consider, which I think is something that Marie mentioned is this whole 4th trimester of care, because we have a lot of bad outcomes in that 4th trimester when we think about depression, maternal depression, maternal suicide, some of the complications that particularly Black women are dying of. They often happen in the 4th trimester, and we could return to that whole notion of the childbearing year, which would allow us to look at both preconception care and then that 4th trimester.
So to clarify, Phyllis, because I want to make sure I'm clear, are you saying that being a 4th priority area, or are you saying make it part of understanding what is working around the country, make it another priority area? Okay, thanks. Yes,
I'll add something, Belinda. Thanks. I actually like the impactful opportunities word, but I kind of think we should focus this, not on all impactful opportunities or all disparities or inequities, but I think we should focus this on Black individuals. And I say that because of the data we have and the stark disparities that we see. And if you kind of go to rural groups, you go to urban versus rural, it's sort of all over the map a bit, but these disparities exist for Black everywhere, so that's kind of where I would go, and spreading, looking at really what has worked and what's going well in certain places. I just think that we can't, I think I said this yesterday, we can't not include that right now where we are in things. So that's my thought.
thank you, Kate. Yes, Steve.
Yeah, I agree. I like the impactful opportunities, just idea, because there are things, and we've mentioned it before, the Strong Start study. I mean, there's a lot of money spent on it. It was part of the Affordable Care Act. It showed demonstrable benefits, in particular, based on race. And so it's kind of like, if we can just say to the secretary, please prioritize that, prioritize the implementation, or making it available to as many communities as possible. So anyway, I like it. I like your consolidation. It is overwhelming at times. And when we had that 50+ recommendations, they're all important, but it just sort of then just becomes kind of stuff thrown into the air and it doesn't really make an impact. I mean, it does. A lot of the work. Yeah. Okay. Sorry. Didn't mean to say that.
No, I think we understood.
Our work group would be to gather where those are, right? Gather what those interventions are, the pockets that have demonstrated improvement, and kind of put that together in a consolidated way. Right? Is that between now and?
That could be a focus of a work group, in partnership with the staff here, and trying to understand what is working to address. And are the others okay with the focus being on Black maternal and infant disparities? Because I don't want to make an assumption. And I also want to give a moment to those that are on Zoom in the virtual area, because if you've got anything you want to say, just chime in or raise your hand.
Just to clarify, Belinda, I don't think these other groups are important, but I think we can get those in
Prioritize.
other priorities, so the rural issues, is listed. That's why I thought we could.
Okay.
Virtual ex officios and appointed members have the ability on meeting.
They can, okay. So if you're an appointed or ex officio member, you can just unmute yourself and speak. You actually don't have to wait for someone to unmute you. Yes.
So I think along this line of impactful opportunities, an important line of questioning to add there would be, to the extent that these are federally funded, where are there opportunities for alignment for things like braiding of funds? We've seen this in the early childhood space, where often states are getting funding from multiple streams for like projects, but different agencies may have slightly different asks, different deadlines, different definitions, and it creates inefficiencies. And in that space, across the federal government, folks have come together to say, how can we use common definitions, share needs assessments, to make precious limited resources go farther? And so I think any time there's an opportunity to look for those efficiencies on the federal end, that would be welcome. And I think on the same thinking there, any barriers that are within the scope of the federal agencies on the policy or programmatic side, that could be, as these come up, what's where I love the thought of bright spots, what's working well and how do we replicate that? And then what are those lessons learned where if this was tweaked just a little, we could do more or do better? And that's a really great role for this committee to be able to take back to the secretary for the things that are under the HHS umbrella.
Thank you, and agree with that. I also think it's an opportunity, as we're looking at what is working, that we don't have to just limit it to what is working in the federal government, because there are foundations and communities that have started efforts in there and using other funds that may be working really well, and we just don't know about it, or they've not had an opportunity to share it with a broader group. So starting with the federal programs, of course, that makes sense, but I think we have to go beyond that as well. So it sounds like we may have agreed on one priority area. You all should give yourself a hand clap. Yes. No, thank you all. And following what Maria is asking, Maria, you've got something you want to say now? You sure? Okay. Let's go to the second bullet then. So if we think about impact opportunities potentially being almost as an umbrella, as Maria has suggested, then the other areas may fall underneath it. So then the question is, as we think of these other priorities, are these some of the other priorities we would like to consider? Should we consider a priority around, as the words went away, rural communities, any of these areas around the second bullet? So we'd love to hear your thoughts on it, or how you want to, reword it or change it, or say, no, we don't want to do that. Yes, Steve.
Yep, coming from a state too, where the North Shore of Lake Superior, there's no hospital between Thunder Bay, Ontario and Duluth that provides birth care, and that's Two Harbors closed, it's Grand Marais, and it's like 3 hours. And so most common, out of hospital birth thing is having a mother give birth in an ambulance on her way down to Duluth. So I think it is something we have to, because we're a big country. We have certainly a larger population in urban areas. But from a political standpoint too, it's not helpful. It's important for everybody to be looked at. And I think I really agree too with making the focus of that number one on the racial disparities. But this is one that really is important. It's getting a lot more attention to people like Harold Miller from the, I think, Center for Healthcare Quality and Payment Reform in Pittsburgh. He's done a real detailed analysis of the financials of these hospitals. And we just maybe need to tap into some of the rural health programs that are around the country. I think there are 8 of them at universities. There's a very good one in Minnesota with Katie Kazumanel that leads it. And to just look at the various possibilities, we don't maybe need to have, except for extreme emergencies, cesarean section capability in places where there's sort of risk assessment, a multiparous mom who just says, I don't want to drive down to Duluth or wait around till my birth happens. So anyway, I'm just putting in my pitch for, yes, we have the rural, and that ties into maternity deserts as well, which some of those are not exactly rural either.
Thank you, Steve. Others want to chime in on the rural health or rural community focus, looking at the hospital closures, the deserts? Anyone else want to chime in?
I can't help it.
You don't have to help, but you can
No,
chime
I'm a
in.
committee member, right? I agree with Steve that I think this is a really important focus. Now, I think where we were, a number of years ago in thinking about, building systems for care and that kind of thing is really different, because this trend that we're seeing with closures is newer, right? And it's something that I very much think we need to address, the way hospitals are aligning and the financial, decisions that administrators are making and the impact on individuals that live in these rural areas. It's very important, and it's addressable, right? I've had the opportunity to visit, I've always worked all my life in quaternary care, tertiary care settings, but I've had the opportunity to visit a hospital in Wyoming that, was many, many miles away from quaternary care, and the system they put in place to provide safe care was amazing, right? But that's one of those bright spots, right? That's not, but as a hospital closes, those systems aren't in place. So how can we rev up to make sure that when there are closures, these safeguards are in place to have systems that work? Maria, I'm hoping you're going to comment too on kind of what's happened in New Hampshire. We just chatted on our way in this morning. There's opportunity to address these things faster than would if we just let administrators do it,
Thank you. Yes, Marie.
Since I was put on the spot, Kay. No, just kidding.
Called you out,
No, you're fine. So yeah, I think if we use the umbrella of impactful opportunities, I think that will help frame a solutions-focused recommendation document for the secretary. One area as far as supporting rural communities that I think we should add is the importance of having residency and loan repayment options for individuals who want to serve in that setting. And so I would want to explore what is already available and what's the capacity we have to expand that. I think loan repayment, National Health Service Corps in particular, has had a tremendous effect in supporting our rural American communities. The other thing I think would be interesting, and we touched upon it yesterday, was how the demographics within rural communities has shifted. So with the economic changes that are happening, with the influx of new Americans and refugees, our rural communities are becoming much more diverse than I think we would believe just off the onset? And how has that impacted potential delivery systems and the effectiveness of those delivery systems? So I think that would also be interesting. And then the last thing, as far as rural communities and identifying bright spots, is in this levels of care. I'm certain that from a state to state standpoint, and maybe even from a federal standpoint, there are different definitions for levels of care. And so level setting on what does that mean for us in the federal space? And then how does that translate into a state setting, I think would be interesting. And then, as we were talking yesterday, what are some unique and creative models to help create extensions and extenders of that tertiary care that people need? So I think, again, in the spirit of highlighting bright spots, that would be a nice way to incorporate that topic.
So appreciate you bringing up National Health Service Corps and the residency issue. So HRSA has a whole Federal Office of Rural Health Policy and the Bureau of Health Workforce that are both amazing. And so we could easily tee that up for a future meeting. And I think there's been a lot of interest in how that work expands. So appreciate that. I also want to piggyback on this levels of care notion. And I go back to thinking about how we let data tell the story and inform our story. I remember when I was in state government and we had a regionalized perinatal system. And, hospitals pay attention to those numbers because and I'll speak on the neonatal side, because there are payment implications. And so purely because of that, there was this, well, we think we're a 3, but really we're a 2. So we'll create this separate system of 2A and 2B. So we create all these structures to sort of make everybody happy, right? But colleagues in other states started to do analyses where the hospital assessment, self-assessment, and the objective assessment were discordant. And there's good data, I think, that shows outcomes are better when those births happen at the right place. But when there's a discordance in the self-attestation versus the objective application, those differences aren't as pronounced. And so I wonder if there's an opportunity to lean into those data and look at that, and with all the maternal levels of care work that's going on, to think about both the maternal and, is this package deal, right? The dyad, and think about how that might drive some of this work.
I'm glad you mentioned that, Dr. Warren. The other impact because of that is the consolidation of hospital systems. And so when we talk about residency programs, for instance, there needs to be a hospital that sponsors the program typically. And so if we're trying to get access and create a pathway into rural communities, and we're consolidating those options even further, it makes it much more difficult to expose potential clinicians who would not otherwise think of working in those areas. And so I think making sure that the data is in alignment and is saying the same thing helps us to make a stronger case of keeping hospitals open and creating a trending, right? We can create trendings to help explain from a fiscal standpoint why it makes sense to keep those health institutions open. So thank you for bringing that out.
So thank you all. It does sound like this is a priority area that we do want to try to move forward with. I haven't heard anyone say any reason why we should not. So let's go to the third one around social determinants of health, or those social drivers of health. Any thoughts on this specific priority area? Realizing that there's an HHS report, the highlights were shared with us yesterday for us to look at last night. There's been some conversations around what are the Medicaid waivers doing? What is actually under the purview of the secretary versus where does this fall somewhere else? I know one of the conversations I had with Dr. Warren at one point was around, so when you put funding opportunities announcements out, and it includes social determinants of health, can you actually use the funds to address the social determinants of health? And sometimes it's a mixture. So, you may can purchase a transportation voucher, but you may not be able to help pay someone's rent for a month or two, right at the time that they need it. So it's also thinking through all of those pieces as well. So any thoughts from anyone? Yes, Kate.
So Belinda, I went and reread Andre's, I guess it was his slides last night, and I mean, his presentation is pretty comprehensive, and there's some wonderful even recommendations right within that. My question, I guess, is what's our committee's role or influence above and beyond what they've already prepared in a strategic initiatives? Because do we pull certain things out and say we're behind this, or is it just there already and we don't need to do that because it's done, or we endorse it or something like that? I just don't know how we can best use our influence.
And I think it really is up to us how we want to do that, whether we want to elevate one or two areas from the report, whether there's something that we feel like is missing from the report. If there's, the report was pretty comprehensive, and I agree, Andre did a great job with his presentation yesterday. But we had really good conversations and presentations on housing. So is there one area out of all of that we want to elevate and look at, well, what has worked around the country, again, putting it under that umbrella of impactful opportunities. And we'd love to hear your thoughts on that.
To that point, I'd be interested in hearing from the Federal Housing Association to see if they've considered ways to incentivize preventive care and maintenance with their funding. So HUD, typically takes care of lower incomes, lower socioeconomic populations. And so I wonder if it would be beneficial for us to hear what is currently happening and if there's any cross-pollination already. I think the evidence and the data is very explicit that housing and transportation and food insecurity are the top three. I had to look at Carolyn there. So the top three areas of, as far as social determinants are concerned, that can help just shape and transition the complete outlook for a person's well-being. So has there been a coming together and a convening of the Secretary's office, and Housing Authority? So in Boston, I say this because in Boston, there have been some unique programs where they have embedded primary care within specific housing neighborhoods and have incentivized and provided additional funding for people that are residents there in order to promote healthy living. And that might be a unique approach. And I don't know if it's been something that we've talked about. So would that be possible? And I'm looking at Michael for this.
I'll also kind of key up and Valika, if there's anything you want to chime in and share as well.
I think one of the things encouraging, like one of the things already of the department, and that it's easy enough to pull together those partners and think about where are their shared goals and metrics. And I think about, as you were talking, I was thinking about some of the recent infrastructure implementations and some of the funding around certain manufacturing groups being tied to childcare also. And so, are there related metrics that cross domains that folks might not have thought of previously? So in that example, childcare and manufacturing. In this example, housing and maternal postpartum visit or well child visit or something. Are there ways to link those together? That's certainly within the purview of this group to make that recommendation.
Thank you so much. Alika, is there anything you want to chime in and say?
So we have models in a sense that we've done. For example, coming out of COVID, there have been some real great relationships and intentional meetings and programs between our public housing authorities and the FQHCs to make sure that the residents that live in HUD assisted housing have that connection. But when you look at the funding that we've just released to deal with the housing crisis, and in particular, the unsheltered individuals on the street, we've released different funding to address the social services piece of it, to make sure that there's a voucher in place, but also making sure that there's funding coming from HUD to landlords or continuums of care community-based organizations to address the mental health piece of it, or the substance piece of it. So not talking about maternal child health right now, but there are ways that we have, and great models of working with other agencies around housing. And another piece that I was mentioning yesterday after our meeting, we have organizations that we've provided funding to, like Breaking Ground, Common Ground, where they've developed new construction, affordable housing, supportive housing, and there's a medical office on site that the residents have access to their doctors, a primary care physician in the building. And there's also models where they're developing just new construction, affordable housing for formerly homeless families that now have urgent cares that are built into the base of the building. So we see this happening in many places across the country. It's just really about how do you turn it into a real like program or initiative or structure that can be expanded or utilized across the country, if that makes sense.
It does. Thank you, Alika. We appreciate that. It sounds like we may want you to present at some point on some of all of these impactful things that you're doing around the country.
But you know what, this is the last thing I'm gonna say and I'm gonna shut up. I'm done. But one last thing, right now, related to the lead-based paint issues that we're having in our properties, we're working directly with HRSA here to make sure that whatever programs or opportunities that they have in place that are directly related to lead paint or lead, we're working with HRSA, but we're also working with EPA because they have a certification program. We're also working with SBA to make sure that if residents in that community want to work or get certified to work in companies so that they could be the ones that go in and make our units safe, they're the ones that are doing it. So it's an intentional collaborative effort to address our lead issues in our units across federal agencies. So that's something that we're doing on a regular basis, and it kind of puts me in the mind of what we're talking about today. That's it.
No, thank you. We'll come back to you. We're not gonna let you be quiet the rest of the meeting. Anyone else, any thoughts on this particular priority? It sounds like it may be something we wanna get a little bit more information on and see what may be working in these areas and see where there's an opportunity for some overlap, so collaboration with other efforts. Yes, Kate.
Don't let me talk too much. One of the things that resonated with me in his presentation in the list of goals, a lot resonated with me, I'll say, but the goal 2 is to improve access and affordability, equitability, delivered care, and support partnerships between healthcare and human services providers, as well as build connections with community partners to address social needs. I think there's incredible potential there that's untapped. As a provider who talks to a lot of providers, the idea of shouldering the responsibility for addressing social determinants of health is like, not my job. I can't, I don't have the tools, that sort of thing. But if it's possible to build those tools, right? And we heard from our community representative that she would engage more readily and trust and address the systems if that was recommended by her provider. I think that's powerful. I think we tried to do a bunch of that when I work in North Carolina. So I think that's worth kind of digging into a little bit more about implementation. And if we're asked to screen as clinicians, like we're in primary care, CMS is asking us to do that, but it's happening in primary care, not so much in the OB, at least at my institution. In the OB and pediatric world, not so much. Not my job, I do pap smears, but it's huge potential. And I think that if we make it and we educate and we make it implementable, there's great opportunity there. Family medicine, that's probably, yeah.
Thank you, Kate. And so let's go to this next priority, because I'm also looking at the time. And if you can go to the next slide, please. So the last one that I had put on the list was the impact of pregnancy intentions, whether it's the impact on the systems, the individuals. Don't know if anyone has any thoughts on this one. So more probably around, this is some of the wording that came from the party around reproductive justice and reproductive intentions. So maybe pregnancy intentions is not the best word. Mhm. Any thoughts, concerns? Want to stay away from it? Want to delve deeper into it?
So I'm thinking preconception
Mhm.
care when I think about pregnancy intention and accessibility to preconception care.
Okay.
So with that, again, in the spirit of looking at particular populations that would benefit from additional insight, I think about new Americans, I think about incarcerated people. I think about families who have housing insecurity as well, that might be limited to accessing preconception care. I think this would also, there's some blurred lines because state level initiatives and policies affect access to preconception care. So again, I think that would be interesting to identify some bright spots. What evidence is there available that has shown some positive effects to that regard? I also think the impact of pregnancy intentions that could fall into line with that fourth trimester care as well. So concepts like expanded Medicaid, and in the states with expanded Medicaid for 12 months postpartum have actually demonstrated lower postnatal complications and effects. So that's sort of what that makes me think about. I'd like to hear what other people have to say.
Yes, Stephen, and I think Phyllis, were you going to say something? I didn't want to cut you off either.
Oh, sure.
Yes, Steve. Mhm.
Yeah. So Belinda, thank you. I think the way you worded it is really helpful. I wish you were the Speaker of the House or something, US Congress. You have a knack for saying, okay, certain things are hot buttons that are going to just get a backlash. So anyway, I just wanted to say, I just appreciate how you address that. And I think it would, I think it would get a lot of support kind of with our major divide on a whole variety of issues, but particularly that one.
Thank you, Steve. Yes, Phyllis.
Well, I mean, there is also reproductive coercion where women don't have access to birth control. And I think, we may need to think about that as we see what's happening with other access issues to care. Not only women having access to abortion care, but also providers who are not willing to offer services in cases that they should because they're worried about their own license or, that kind of thing. So I think we're in a time where there are a lot of threats to mechanisms that women use to control their reproductive health. And maybe there's a way I need to take a deeper dive on that. Because something else has to be accessible when you take away another part of care that they should be entitled to.
No,
pursue.
thank you, Phyllis. And thank you for specifically calling out coercion. I think that was a piece that we had missed. So thank you. And I want to make sure there's no one online that has anything they want to say. One online? If not, Marie is in the room and turn it to you, Marie.
Thank you. I definitely agree with the sentiments that were expressed. I would like for the committee to consider, if we do discuss social justice and around pregnancy intentions, that we maintain a very specific gaze so that we have a controlled conversation. Because what I don't want to happen is this is one part of maternal infant health, but it is not all of it. And there might be areas of opportunity that are more readily actionable as well. However, I do see that we might have opportunity, particularly, I'm again, as a National Health Service Corps um, recipient, I think often about, our federally qualified health centers, our rural health centers that are required to provide certain services for the most historically excluded populations, and how does that affect, these populations of priority that we've identified. So again, making sure that we have actionable recommendations to the secretary, and not shy away from the discussion, but where are some bipartisan bright spots that have been demonstrated and could potentially be replicated in a way that is effective to reduce disparate outcomes. So that's my recommendation.
No, thank you so much, Marie, because I think that is the focus, is we're trying to get to an area where we can actually have a good conversation about it without people going into their own corners of the room. We've got to, bring this to the center and figure out how we can move some of this work forward. And that's going to be critical in our discussions as a committee. Yes, Kate.
Well, and I'm not sure, and others can educate me on this, but I'm not sure that we really have a good system in place yet to really monitor the impact that these changes in policy and our requirements are going to have on maternal morbidity and mortality. So that would probably be factored into recommendations that we should include. And that would be something I think that, and I think the issue of improving maternal health gets bipartisan support, so that would help.
No, and I think that's a great point, Kate. And I think every community is probably trying to figure this out and I think it gets to this next point here is, what about data, anything on research? And specifically, what data or research do we feel like we need more of? Do we feel like the data that we get now, realizing that, we get some really good data, but data, we always want more. And so is there an area of data or research that we feel like should be factored into any of these priorities as we're moving forward? Yes, Steve.
Sure. That's why we have Danielle on the.
She see her smile when we said data, didn't you?
Yeah. But really, we had a short discussion about a study that we were doing on outcomes. And I would just be interested, Danielle, if you have any thoughts on if you had every wish you wanted about how, there are 50 states plus territories and everything, and it's sometimes a mess. It's getting better. But do you have any thoughts?
You didn't know you could make wishes today, Danielle, did you? So thank you.
So I know one of the things that we've been working on at NCHS in general and with vital statistics is getting more timely data. And we've really greatly improved it in some areas. And we're working on improving it for infant mortality and specifically the linked file, which is, I don't want to say woefully behind, but it's one of the things I brought up yesterday. Was just last week, we were able to get out our 2021 data. And so we're trying to find ways to improve timeliness. One of the issues you're talking about, wish lists, one of the issues we run into is that states need money to collect data. COVID really impacted the vital statistics reporting just all around. But states were also given money related to COVID that could be used towards vital statistics. So it's this twofold. I don't know off the top of my head, I can't necessarily think of anything specific wish list wise, but there's always the hope that people can get in better data, and the move to electronic health systems is helping in some ways, and finding automated ways to code cause of death is helping, but some of it just takes time to get implemented and to test. So it's hard to say if I would have a wish list, but my personal wish is that we would be able to find a way to get our data out earlier, but a lot of that is internal. So
no, and Danielle, you can keep thinking about it. You don't have to just give us your total wish list right here on the spot. We'll come back to you at some point in a future meeting soon, because we do want you to think about it. I know some of you have said to me, you feel like we don't have enough maternal health data to actually track what some of the outcomes are. Some have said similar things on the infant front. I think we probably have nationally more infant type data than we have maternal health data. So is there an area there that we want to delve in any further, or are we comfortable with the data we have? And that's the reason I just added that data research piece. Yes, Danielle.
Just if you can tell us like what you want. This is what I always said at the last committee as well. Some of you were on it. It's like, you just need to tell me if you want something.
You may
just
have
kind of-
that already and we just don't know it.
Yeah, and so I know one of the times it got brought up like, oh, we need more AIAN data and multiple race. And it's like, well, we have it, but no one's asked me for it. So I just want to put it out there. I can't guarantee we'll have what you want, but if you don't ask, I can't tell you.
Melinda?
Yes, Kate.
I think one of the struggles we have, and I work enough with the maternal morbidity data and that kind of thing to sort of know what CDC does, know what HRSA is trying to do. It's just kind of what picnic, different quality collaterals are trying to do and things like that. And it's not. Bill Callahan provided us with a really great starting point, but it's not enough, right? To look at morbidity with the birth hospitalization. It's pretty well expected that we need to know. We need it throughout, the postpartum period. We need something broader than just what happens in the hospital. And administrative data has flaws, and that's kind of what we're working with. And people are thinking a lot about, how can we expand that standard? But we do need a consistent way to describe maternal morbidity, and to have a system for surveillance. And so, Danielle, I don't know what to say to ask for, but we do need to get all the right people around to decide. CDC, HRSA, people who are AIM, people who are doing this work and actually, you may know more about this, Christy, than I do, because I think people have gotten together to try to do this, but I don't know that it's been widely accepted. So wouldn't it be great? Oh, I do say that too often, but wouldn't it be great to have to come up with, a consensus from all the stakeholders that says, this is the way we're going to do it. This is the best we can do with what we have, and ask Danielle to push it out.
Well, and it's not just me, right? Like, because but what I am saying is, if you ask, say, we're interested in X, Y, and Z. So, what can you provide, or what can this institute, like very specifically, what can your center, institute, office, whatever, provide on that specifically? So I know for us, I can tell you different, national rurality, infant mortality. We can talk about, well, I'm not sure how much my colleagues from mortality could talk about, maternal mortality in rural places. There are a lot of things we can touch. It's just, we have to know what you want us to even look for to start with.
I think in previous presentations, the recommendations, there's, PRAMS is there. That's great. MMWR, the maternal mortality review committees are expanding. That's fabulous. There's timeliness. It's mentioned numerous times in the reading that we got last night and previous recommendations, so blueprint, et cetera. That's all there, but the topic of a better measure of morbidity, I don't see it in that yet. So that's kind of something different.
As we think about with colleagues what those measures might be, one of the things, keeping our public health hat on, we're talking a lot about outcome data, but then the outcome has already happened, and it's often the outcome we want to avoid. And so what are those upstream markers, particularly as we think about preconception health across the life course, that we might put as flags that are not going to be quick fixes, but this is multi sort of generations of career work that over time will start to bend that curve.
Thank you. And Charlene, I think you wanted to speak. Please chime in, dear.
Yeah, thanks, Belinda. Sorry, I didn't want to interrupt the flow, but just wanted to highlight what Kate mentioned, that it's really important to examine maternal morbidity beyond the delivery hospitalization. We think we have a good understanding of that, and we're working with our great partners at HRSA and AHRQ to continue to refine what that might look like. But in addition, it's really understanding those morbidity events that happen prior to delivery or after that I think is important to emphasize. And just also wanted to mention too that respectful care is important, not just at the delivery hospitalization where we do have a lot of data, but before and after. So that's another area where I think that this committee could consider having an impact. Thank you.
Thank you, Charlene, and thanks for chiming in. I just want to do a quick around the room for those virtually that if we haven't heard from you and you've got anything you want to add to it. Sherry, I know you're on now. Sherry Alderman, don't know if you want to add anything to this discussion on priorities. And then I'll call on Sharonda after you. And then I think Tina is on. Is there anything you want to add, Sherry?
No, thank you for asking, not at this point.
Thanks, Sherry. Sharonda, anything you want to chime in with?
That is,
No,
the
everyone
EI
has been
portions, that's
definitely
ones that I'm kind of working on
hitting the
for
right
them.
points.
Thanks.
I'm still working.
Tina, would you like to add anything?
Hi, no, I think you all are on the right track, certainly in line with a lot of the work that we are putting out moving forward in IHS. So happy to learn more from what the work that you do. Thank you.
Thanks a lot, Tina. And I think Karen, I think you're on, Karen Remley. If you want to chime in with anything.
I don't have anything to add. I fully support this and will be really think it's important to really have our focus narrowed.
Wonderful. Well, thank you all. I just want to make sure if you were trying to say something, we got a chance to hear from you. So we only have like 4 minutes and we have narrowed this from 12 down to like 4 or 5 areas. And our next steps, we're going to have to kind of figure out how to divide and conquer. So as you go through the day, start thinking about if there's a specific area, and we'll try to get it put on a slide during the lunchtime period that you want to really focus on, realizing that we have around 10 members now. So I don't know if we're going to do 5 work groups. So we got to figure out how to manage that. But let's think about that the rest of the day. If you are one of the members, including the ex officio, we want to include you in this discussions, not leaving you all out by any stretch of the imagination. And then we'll come back to that at the very end of the day. Okay, anybody have anything else they want to add in? We do have another minute or two as our panel gets ready. Yes, Marie.
Thanks, Belinda. I did have one data question. I saw your ears perk up. So something that we know is both helpful for on the maternal side in preventing adverse outcomes and on the infant side is success with breast or chest feeding. And I know we have programs to help encourage breastfeeding postpartum, but do we know or do we have information about the length of continued breastfeeding within that first year postpartum, and then access to supportive services to encourage breast and chest feeding in the peripartum period? I say it that way because we do have a certification for hospitals that are breastfeeding or chest feeding friendly, but I wonder if the populations that are most affected, and we're talking about our Black and Brown populations at this time, if they have the same measure of intentionality with supporting breast and chest feeding in that peripartum period. So we haven't really talked a lot about our infants, but that seems to be a natural overlap.
You and we should make sure that as we're looking at our priorities that we're thinking infant and maternal. So thanks a lot. Okay. Anyone else? You've got a minute. I'm adding breastfeeding to our data research area. Okay, well, wonderful job. You all should, again, give yourselves a hand. We narrowed this down much better than we thought we were. I was real nervous about that one. I was like, okay, this is gonna be a long day. Okay, so now we're gonna transition to our panel. I think all of our panelists are here. At least I'm getting ready to find out. And we're gonna ask our panelists to come to the front of the room and there are mics there. When you get up to speak, if you want to stand at the podium, you're fine to do that, but we would like to get all of you all at the front, and that way when we get to Q&A, you'll already be up near a microphone. And so we're going to start with Julia Scappick. Thank you, Julia. You just knew I was getting ready to pause on your name. Julia is the Chief Medical Information Officer with NAC, the National Association of Community Health Centers. Happy to have Julia with us. We'll also have Christy Allen with us. She's the Senior Director of Quality Improvement and Programs for ACOG, known as the American College of Obstetricians and Gynecologists. We have Karen Jefferson here with us today. She's the Director of Midwifery Practice for the American College of Nurse Midwives. We have Jonathan Webb with us here today. He's the Chief Executive Officer for the Association of Women's Health, Obstetrics, and Neonatal Nurses. And we have Deborah Waldron with us. She's the Senior VP, Healthy and Resilient Children, Youth, and Families for the American Academy of Pediatrics. So welcome. We look forward to hearing from you all. One of the reasons we invited all of them here today was to really kind of share with us what some of the priorities are of their organizations. One of the things we've been talking about as an advisory group is really thinking through where there are opportunities for alignment with our recommendations, with all the work that you all are already doing. So we'd love to hear your thoughts on that, and we'll just let you go in the order. And I think we'll start with Julia.
Okay, testing.
You're
All
good.
right. Thank you so much for inviting NAC to participate today. I'm Julia Scappick. I'm the CMIO at NAC. I'm an internist and board certified clinical informaticist. And NAC is doing a lot of work in the area of infant and maternal health. And we would love to partner with some of the folks who've already spoken at this meeting and see how we can deepen our relationships and maybe, assist HRSA and its evaluation across the industry. Next slide, please. So this is the NAC mission. NAC was founded in 1971, and NAC takes on 4 sort of major roles: doing research-based advocacy, education about the mission and value of health centers, training and technical assistance to health center staff and boards, and clinical workforce, innovation and performance. Next slide. These are NAC strategic pillars. I would argue that all of them touch on the topics of interest to the advisory committee. Obviously, equity and social justice, first and foremost. I'll talk a little bit about some projects that seek to build infrastructure or support infrastructure around maternal and child health. We do a lot of workforce programs, and I loved hearing yesterday about the diverse workforce that HRSA is working with. NAC obviously also works with the same doulas and midwives and nurse practitioners and patient navigators, community health workers. I think obviously there's a lot of room for partnership there. I would say for 4 and 5, many health centers are working on improved care models, both from the payer side and also sort of from the innovation care model side. And of course, those hopefully will lead to reliable and sustainable funding for the patient-centered dyad family care team support that we need to do better in this area. And then supportive partnerships. Again, I'm here because I'm hoping that we can continue to deepen and broaden our work together. Next slide. So many of you are probably familiar with the beginning of the community health center movement. It started in the beginning of the civil rights movement 57 years ago. 2 rural and an urban health center opened together, specifically with the hope of addressing health disparities. And you'll see those 2 initial health centers on the slide. Next slide. Today, NAC supports 1,400 plus community health centers, which have over 14,000 healthcare delivery sites. In 2021, we treated more than 30 million patients, and that included a large number of special populations, as you can see on the slide, many uninsured rural residents, and actually the majority of health center patients are living in poverty or under 200% of the FPL. Next slide. So there are 5 things that make you a health center, and I'm sure HRSA folks don't need to hear this, but you have to be located in a high need area, provide comprehensive health and related services, including enabling services, which I think is within the scope of what many folks now talk about as HRSA or SDOH. You have to be open to all residents, regardless of the ability to pay. Governed by community boards. One of the cool things about working at NAC is meeting community board members. And following, of course, reporting and performance accountability requirements. Next slide. So health-centered, patient-centered care. So primary health services at health centers are largely, but not entirely, in sort of 5 domains: family medicine, internal medicine, pediatrics, obstetrics, and mental health. I would argue that basically all of those are overlapping with the scope of the advisory committee. But we also do things like dental screenings. I actually know a number of health centers have prenatal dental programs where they intentionally enroll their pregnant patients into a dental screening. Many of them have gone many, many years without dental services. And of course, the enabling services, I heard a number of programs doing that yesterday, which is fantastic. NAC has a number of programs also, or health centers have a number of programs where they work with dyads where there's a housing insecurity or homelessness and people who are in public housing. And of course, those pregnant patients are at higher risk. Next slide. So when you look at the overall population that's either in the maternal or infant time, sort of stage of life, I'll say, that gets close to about, just under 10 million patients a year. I think we can go to the next slide, actually. So I want to talk about health centers focus on mothers and children. On the left here, you'll see this is from our May 2023 Care Teams Digest. We featured a program that we have at NAC where we do self-measured blood pressure with obstetric patients, knowing that hypertension and hypertension-related disorders are a significant cause of morbidity and mortality. And in 2020, health centers served over 16.8 million women, provided over 500,000 prenatal care, delivered 170,000 infants. This is 2020 numbers again, and provide contraceptive management to many more patients. Next slide. So I want to talk about a couple of programs that individual health centers or networks are working with. The one on the left is one of my favorites. So Andrew Hamilton, who's the CIO at Alliance Chicago, said, we're using children as lead sensors, and we shouldn't be doing that. And I think that that's a really valuable statement. So this program actually goes into the homes of pregnant women, does the lead screening, and does the abatement before the baby is born. It's a program aligned with the city of Chicago. And obviously a very forward-thinking way of addressing lead exposure. And the maternal health program featured, this is actually from the lay press on the right-hand side, at a Detroit Health Center, is about sort of doing more patient-centered care, more group support for patients who are at high risk, providing them with more patient navigator and care coordination services, much like some of the programs we have already heard about. Next slide. So we have some programs funded with the Centers for Disease Control. Thanks to anyone who's on the call from there. This project, the first one I'm going to talk about, we call it Women's Health PP, but it's really Women's Health Postpartum Quality Initiative. It actually came from several CDC groups, and we sort of merged the project over time to be more focused on comprehensive quality in the postpartum period. And so this project has been going on since 2018. We are focused on using EHR and population health tools to track postpartum care quality. Over time, we've added more and more quality measures to that flow, but our partners have also done workflow re-engineering in the electronic health record to create centralized areas where the care team can find information about what services have been provided and which services are needed for specific patients, so targeted for all of those measures that are relevant, and also trying to streamline that to make it easier for the care team to provide those services with less burden. Next slide. These are the partners that we have currently working with. Alliance Chicago and Ocean have been on board since 2018. Together, they serve about, I think, 10 million patients in the United States. Redwood is a smaller network we're working with, doing some work with Medi-Cal in California. And then CMQCC, probably everyone here is familiar with them, the California Maternal Quality Care Collaborative. We've been working with them on sort of the improvement of the specifications of these quality measures, and they've been working on that in California as well with the state. Next slide. These are some of the issues and things we've tried to address during the project. One of the biggest challenges we run into is just the poor quality of data around pregnancy. And NAC since 2020 has been repeatedly submitting comments to the Office of the National Coordinator for Health IT around the need to support all of the continuum of metadata that supports a pregnancy episode. We were pleased that the third time we submitted pregnancy status that was accepted into USCDI, but we know that that's absolutely insufficient to do the work that we need to actually track the state of the pregnancy and then the outcomes before, during, and after the childbirth. And we've also worked with the partners on improving the completion of that documentation and the record of the actual delivery date. Even with targeted effort, outpatient records, 50% of the time or more will be missing the actual delivery date, which is needed to drive all of the quality of care and decision support that the care team needs. Obviously, you can't do a 3-day follow-up if you don't know the baby has been born. And we are considering some projects wrapping around a patient navigator to help fill in those data gaps so that they can also communicate with the patient about the importance of that follow-up and bringing them back into the fold as soon as the baby is born. We can go ahead to the next slide. I'll say that the scope of our quality measures include gestational diabetes and diabetes, hypertension, substance use, postpartum depression screening, and I'm feeling, just the postpartum comprehensive visit. So this is actual data from our project. We have 104,000 total deliveries as of the last data analysis. This is a breakdown of the number of patients who had different conditions with hypertensive disorder. And some of the measures that we were working on this area is the use of aspirin in patients with hypertension-related pregnancy-related hypertension, and also an early follow-up visit or early follow-up blood pressure. We also look at preeclampsia screening. Next slide. This is a newer component of the project, as a MMRC and PQC collaborative, also sponsored by the CDC. Thanks again. The goal of this work is to convene and establish a model for state and national collaboration with health centers on perinatal quality and maternal mortality. So the idea is a data-driven approach where at the state PQC level and the state sort of PCA, so health centers have primary care associations, which are state-based groupings of the health centers, that they're looking at that state level data and using it to say, in our state, what's the biggest threat and how do we address those threats at a state level? And we're also seeking really to broaden the focus of the perinatal quality collaboratives. Traditionally, many of them have been heavily focused on the birth episode inpatient and done very little, if anything, to coordinate care before and after the birth episode with the outpatient care providers. And so the goal is actually to broaden the scope of PQCs and address health disparities across the care continuum and improve transitions of care, which we know are a serious problem. Next slide. I'm almost done. These are the statewide perinatal quality collaboratives coming up. We're excited that CDC has been expanding the program. Next slide. And then these are our 2 current partnerships. So we're working with Florida PQC with Health Choice Network, which is a health center controlled network in Florida, and the Illinois Perinatal Quality Collaborative with Alliance Chicago. Those folks have already been meeting in person to talk about what their strategy is for our next program year, which starts in August. Next slide. So I think there are just a ton of opportunities for us to collaborate, and I hope that we get the chance to follow up after this meeting. Please feel free to send me an email.
Thank you, Julia. We're going to go now, I guess, to Christy, if you're good. And we'll hold questions to the very end, if you all don't mind. Oh, I'm sorry, Jonathan's slide is up next. We're going to go to A1. Sorry about that.
Good afternoon, and thank you again for the opportunity to come and share with you. I'm Jonathan Webb, the CEO for A1, the Association of Women's Health Obstetric and Neonatal Nurses. Next slide, please. A few objectives that we have for today's meeting, the call. And again, thank you for the invitation to share a little bit about who we are at A1, to provide highlights of our infant and maternal health portfolio, to offer insight from what we're hearing from the field, and last but certainly not least, to explore opportunities for alignment. So our mission and vision to make a difference in the lives of women and newborns. Our members are committed to the health of women and newborns, and we want, as an organization, to be able to empower them, empower our nurse members to care for women, newborns, and their families through research, education, and advocacy. Next slide, please. We are a nursing organization. We have 25,000 plus members, and we represent the 377,000 nurses who are in the women's health, obstetric, and neonatal specialties. Our member profile includes bedside nurses, researchers, nurse administrators, nurse educators, academicians, And we actually just recently expanded our membership base to reach out to and include LPNs, doulas, and others who are associated with maternity care. And we're engaging with those populations to make sure that when we invite them into the fold, we have resources that are credible and supportive of their needs. And we support our members through the provision of education, development of guideline standards, research, programming, and advocacy, among a number of other things. Next slide, please. I'd like to first start with a grounding that we believe that all patients deserve equitable and respectful care. We are coming from the place where we have a firm understanding of the growing U.S. maternal morbidity and mortality crisis and the underlying Black maternal mortality crisis. An understanding of the disparities that exist in maternal and infant health in the U.S., the importance of a systemic approach to addressing these issues. And while we firmly believe and understand that many of the challenges and the solutions to these issues need to be addressed from a systemic and social determinant of health perspective, there is still a large role for the healthcare workforce to provide in addressing this issue. Next slide, please. So along these lines, I wanted to just first start out with an effort that we've been focusing on because we as an organization have realized and acknowledged some of the historical challenges that we've had being fairly homogenous in our membership base. So we have over the last year and a half been really intent about what it means to be diverse, equitable, and inclusive. This is important for us because we need to make sure that as we are building the guidelines, as we're looking to build some of the educational resources that I'm going to highlight a little bit later, that we're doing so with the support of a diverse group of members and a diverse group of contributors to make sure that when we produce these materials and offer this information, that it includes a number of different perspectives. And that's from a racial, rural, geographic perspective, as well as sexual orientation. So this is an effort that we've gone through, next slide, please, and developed these pillars of our roadmap, focusing on transparency, focusing on how we share power, operational accountability, how we internally support our members and our staff around people and culture, and then building equitable systems that ensure our policies and processes are fair and equitable. We've also, in addition to, and during the process of building this, and we were making this available to our members and partners and those who are inside the MCH space, we looked for public comment to make sure this was striking the right note. And then we are in the process of building a dashboard so people can hold us accountable to how we're moving these forward. The reason why I highlight this, as I mentioned before, is because it will impact the way we build our materials, but we also think it can be an example to our members about how you can be transparent around your efforts towards being more diverse, equitable, and inclusive, because that's one of the challenges and questions we heard from our folks. Now that they've been trained, now that they understand or are in the process of understanding, what levels of accountability and transparency exist to make sure that people can see that there's a change and we can track the progress towards it. Next slide, please. This is a long-standing statement that we've had, a position statement on racism and bias in maternity care. We continue to train our members and support their understanding around how to be more equitable, inclusive, and really dismantle the systems of structural racism that have gotten us in the position that we're in today. Next slide, please. Here are a few items that I wanted to highlight around our maternal health portfolio, and I have a similar slide for our neonatal portfolio. I won't spend too much time on these because a number of these items were provided to you ahead of time as leave behinds. But we have a really extensive offering of products for our nursing members. The perinatal orientation and education program is an online module that focuses on some of the essential educational components required for perinatal nurses. These types of education are really important to our members because we've seen a contracting of dollars around training. So our nurse members are coming to us to help to fill that gap. And also, as I'll touch base on a little bit later, as we're seeing the growing number of nurses who are leaving the profession, there are numbers of individuals who are now filling the shoes of seasoned veterans without the proper training. So we're being relied on to help to fill some of that gap. We have about 3,200 instructors who are out and training the healthcare system around fetal heart rate monitoring. There's an extensive maternal immunization program Our maternal fetal triage index educates perinatal nurses about the triage basics and the meaning of obstetrics and nursing and the nurse's role in developing a systemic approach to improving the process of triage. Many of you are familiar with our post-birth warning signs to help to identify any issues or challenges, obviously post-birth. One of the newer items that you may not have been familiar with from AWHONN is a set of staffing standards. We did have a version of this out a few years ago, and we're referring to them as guidelines. We have added some a more evidence-based to the guidelines and are referring to them as standards. These standards are assisting our nurse members and nurse leaders in hopefully having conversations with their administrators about what the appropriate level of care needs to be in their spaces, because we have heard reports from our members that the nurse to patient ratio is just something that is not optimal. So hopefully having this set of standards helps them to have a different conversation with their administration. The obstetric patient safety bundle and our OB triage programs are again tools that we have built, curriculums that we have to educate our members on the leading causes of maternal morbidity and mortality, and put together some suggestions and resources around how to address those obstetric emergencies, as well as triaging some of the challenges they're seeing. The OPS and OB triage programs are also really, we've heard from our members, really helpful in rural settings, because this provides them with some resources that they need to address some of the challenges they're seeing in resource-light environments. And last but not least, about a year ago, we released our Respect Maternity Care Toolkit, and I'll talk a little bit more about that in our next slide. But one of the challenges that we were hearing from our members is that they were going through implicit bias training. There was a great deal of focus and emphasis on that, but we were really hearing from them about what the next step was. Now that they know better, how do you do better? So this was an effort from a member-driven effort to try to provide them some resources on how to do that. Next slide, please. This tool is, I just put this in here so you can see what our maternal fetal triage index looks like. It's in your handouts, so I won't spend too much time here. Next slide, please. And this is the post-birth warning signs that many of you are already familiar with, so I won't spend a ton of time here, but it provides our nurse members with some resources on how to identify those warning signs. Our respectful guidelines come from the place where we treat every patient equally. We're using cultural and linguistic competencies. We understand the patient's perspective. We center the patient, communicate with respect, and are creating collaborative, inclusive, and supportive work environments. Next slide, please. This is a snapshot of our guidelines, of our RMC guidelines and framework. You have a copy of these in your handouts. But one of the things that we do, again, is provide them with some resources around how to have meaningful conversations with the patient that centers them. And you'll see that from the next slide. We have an S bar, please. Next slide, please. That outlines some of the suggested ways in how to frame a conversation with a patient, understanding the situation, identifying and working with them to better understand their background, making the appropriate assessment and a recommendation. So again, this is a way to help to center the patient and meet that need that we heard from our members around now that we have training, now that we understand what needs to be done, what can we do to actually move this forward? Some of the conversations that we've been having around these RMCs, and I'll talk a little bit more about this in terms of ways that we can partner, is how to embed tools like this. AWHONN has a tool. There are other organizations that have developed really meaningful respect maternity care guidelines. How do we embed this in the frameworks within the health systems that allows this to be accountable? Things like the CMS Birthing Friendly Hospital Initiative. If there is some sort of measure that requires these types of guidelines to be adhered to in a similar JCO kind of inspection process, we think we could see more traction with how care is delivered. Next slide, please. Our infant health portfolio, we have the NOEP program we talked about earlier, excuse me for the typo here. The POEP program we talked about earlier, we have a similar version of that, the NOEP toolkit. Again, it's an online module to meet the same need, because we're hearing about the gap in the the outflow of nurses and needing to be able to provide some level of training to bring people up to speed in a really quick and timely fashion. We spoke about the staffing standards, so I won't spend too much more time on that. Next slide, please. So we were offered the question around what does it take to have a healthy pregnancy and birth outcome, and how can more babies reach their first birthday? So there were a number of components that were obviously discussed within A1, and I'm sure within the MCH community that are now part of the AIM safety bundles. And in our opinion, those components are still relevant today, and they permeate a number of our programs and resources that we develop. And the things that those components would address would be readiness, so a process and structure to manage an event, a timely response, a standardized process to respond to issues when they're recognized, reporting, and I think I've heard some discussions around that even this morning, creating a culture of data gathering, monitoring, debriefing, and a continuous focus on process improvement, and then respectful care, obviously centering the patient and partnering with them in the provision of care. Next slide, please. A few elements that were beyond some of the discussions around what was included in the AIM bundles from our perspective is the provision of unbiased and equitable care through a trained perinatal workforce, a diverse perinatal workforce, and a valued perinatal workforce. And I'll talk a little bit about why that's important on a couple slides later. We also believe in order to have a healthy pregnancy and birth outcome, there needs to be support provided for the workforce outside of the maternity unit. There are partnerships that we're entering into now with the American Red Cross to provide some of this work out for around neonatal resuscitation to support births that are happening outside of the traditional care setting. But we've heard from a number of our members, especially those in rural and underserved areas, that there aren't a ton of resources to support them in their work. And then support, as I mentioned here, for the communities receiving cares in those areas, the rural areas, but also in the spaces that are becoming maternity care deserts because of closing OB units. Next slide, please. So here are the challenges that we're hearing from our nursing workforce. As I mentioned before, there is, depending on what space you're in, a growing nursing workforce shortage. There's some data and research that we've seen that predicts that in the next 5 years or so, we expect to have anywhere between 800,000 and 900,000 nurses to leave the workforce. A number of those individuals, I think, are just burnt out because of the sacrifices and the call related to COVID. There was a nursing workforce shortage issue prior to COVID, and I think they were just called upon to do a yeoman's task without the appropriate resources and support. So there's a severe amount of burnout. As I mentioned before, since we are seeing and anticipating a great number of nurses to leave the workforce, we're hearing from them that the training to backfill is inadequate and insufficient. So we're trying to fill that gap and support them in that effort. Nurses are feeling undervalued and overworked. I'm not making this statement to cast any judgments or aspersions on healthcare systems who had to do what they needed to do to fill the need, but there was a huge disparity created between what I would refer to as the rank and file nurses who are in the space in the hospital setting already, and those travel nurses that had to come in to fill gaps. The disparity in pay and support is huge. And you're hearing from a number of individuals who just feel like they're being undervalued and underappreciated in that respect. Alluded to the fact that those units are also severely under-resourced. And then last but certainly not least, we have an advocacy agenda around all of these elements, but one of in particular interest to us is the workplace violence that nurses are experiencing. So in addition to those individuals who are burnout, overworked, underpaid, many indicate they feel unsafe when they come in to do their jobs. Next slide, please. Opportunities for alignment. I would not be doing my job if I didn't say that we would love to get support to increase utilization, access to the resources that I mentioned are provided. But I also acknowledge there are many other organizations that have really credible and important tools. And if we can do our collective best to amplify and scale up those training tools, I think that would be a huge win for the MCH workforce and community. If we can have a collective effort towards diversifying the nursing workforce, and I would expand that to include the perinatal workforce, support the adoption of staffing standards to make sure that not just equitable care, but quality care, but equitable care because the patient and the nursing ratio is adequate. Accountability, as I mentioned earlier, around the guidelines, linking this to some sort of measure that requires health systems to put things like this in place. And then last but not least, one of the things that we've been working on with the American Nursing Association is how to utilize this NPI, the National Provider Identifier. Many individuals use this for a tool for reimbursement, but a secondary benefit would be ways to track the nurse's contribution to the birthing experience. Right now, nurses aren't even factored into that equation. So it's very difficult then to determine if the standards that we're producing are valid, how our nurse is actually being utilized in the space. So if we start to track our nurses' contribution to the birthing process in this way, I think that level of data would give us some insight that would tell a very interesting story. Next slide, please. With that, thank you for the opportunity. I look forward to answering any questions we have at the end of our time.
Thank you, Jonathan. I'm almost afraid to say who is next, so we'll just see what slide comes up. Might be the easiest way. Oh, so we're going to start with you, Christy, then.
Thank you so much. I want to start by thanking the committee for an opportunity to speak about ACOG's work to support healthy pregnancy and birth outcomes. If you are not familiar with ACOG, we are the professional association for OBGYNs and obstetricians and gynecologists, which was founded in 1951. As you can imagine, we've evolved just a little bit since then and currently have over 60,000 members. ACOG's stated mission is to support our members to improve the lives of all people seeking OBGYN care, their families, and the communities. Work at ACOG is focused on supporting patient care throughout the lifespan continuum. We achieve this through publication of clinical guidelines and other publications, provider education, patient education, and population health projects and supports. I'm going to talk a little bit about each of those collections of work and offer some examples on how the various programming fits together to address clinical conditions that impact pregnancy and birth outcomes, such as perinatal mental health conditions. ACOG is maybe best known for publishing clinical guidance to direct OBGYN care, which is developed by expert committees. ACOG guidance is often used to establish policies and standards for care nationally. As an example, ACOG released 2 clinical practice guidelines this month in response to providers' desire and need to integrate perinatal mental health into the care they provide. One of the guidelines is related to treatment and management of mental health conditions in the perinatal period, and the other is focused on screening and diagnosis. Provider education at ACOG encompasses a full spectrum of professional development, from new physician training for resident physicians to ongoing professional development for more experienced providers. Building on the example of the mental health conditions I just mentioned, ACOG recently provided sessions on supporting perinatal mental health at our annual meeting, which provided education for over 4,000 attendees. The sessions that were included around perinatal mental health included building clinician capacity to address perinatal mental health, as well as screening, diagnosis, initiation, and management of psychopharmacological treatment. Patient education resources are also developed by ACOG and are maintained on a patient-facing website. ACOG's engagement in developing resources for patients helps assure that clinicians and patients have accurate, aligned, and timely information for shared decision-making. The site provides things like answers to frequently asked questions for patients on a variety of topics, including perinatal anxiety and depression, as well as articles by experts and patient education infographics. Finally, ACOG is fortunate to be engaged with a variety of partners and funders focused on population health work. We work with the Centers for Disease Control and Prevention, with HRSA, Indian Health Services, private donors, and a variety of other partners to address, and I have to say this list is in no way comprehensive, fetal alcohol spectrum disorder, immunization and pregnancy, obstetric emergency readiness, contraception access, early pregnancy loss management, and programming to address maternal mortality and severe maternal morbidity. Through one of these programs, we had developed a perinatal mental health toolkit specifically for clinicians that's available on the ACOG website. And another program at ACOG that I think most of you are familiar with and also support is the HRSA-funded cooperative agreement, the Alliance for Innovation on Maternal Health, which folks have heard mentioned today as the AIMM program. The AIM program provides technical assistance and capacity building for 49 states and the District of Columbia. And those states are working to use patient safety bundles to make birth safer and improve maternal health outcomes and save lives. All AIM resources seek to integrate specifically respectful, equitable, and supportive care for all of the patients that are served, and are seeking to address health inequities that contribute to the known disparities in maternal health outcomes. The AIM program recently released a perinatal mental health conditions bundle, staying with our theme. That patient safety bundle is a collection of best practices and is accompanied by both a data collection plan and resources for implementation. All of these are developed with input and support from multidisciplinary partners, some of which I'm joined by here today, and also include patients with lived experience as subject matter experts. The AIM program is incredibly fortunate to be able to leverage both internal and external expertise to be responsive to what we hear about from professionals around the nation, such as hospital obstetric care closures, staffing turnover, and shortages, as we've heard mentioned. AIM recently released an obstetric emergency readiness resource kit, which prepares non-obstetric or lower resource settings to manage and prepare for emergencies in the perinatal period, including for folks experiencing mental health conditions or crises. When state nurse leaders let us know that the use of contract travel nurses during the height of the COVID-19 pandemic was disrupting safety bundle implementation and quality improvement bundles, or implementation of quality improvement bundles, the AIM program also developed a brief video module entitled AIM at the Bedside, which is available on our website. The video serves as a quick resource for training new and temporary staff to better understand how facilities and staff members engage with the AIM program to improve care and outcomes. It's not possible for me to cover the work that ACOG does, all of it anyway today, participating in around a few of the other pieces that I'm not going to go all the way into are quality metric development, health policy advocacy, Indigenous health program, quality and safety training, and on-site review of the quality of care provided at specific facilities for obstetric care. While less of the focus of this committee, ACOG also engages in resources and guidance that support gynecologic care, including oncology. Through this variety of work and partnership, ACOG is very proud to support care that improves and contributes to healthy birth outcomes for families. Short and sweet.
Thank you, Christy. I'm sure we'll have a few questions afterwards. So we'll go to Karen. Okay, gonna switch places, great. I totally understand.
Thank you, committee, for inviting the American College of Nurse Midwives to participate in this panel.
Thank you. And let me just say that my description of the work at ACIMM is going to be a little bit more upstream than some of the other organizations. And I think when I go through it, you'll understand why we're focusing on what we're focusing. So the American College of Nurse Midwives is the professional association that represents certified nurse midwives and certified midwives in the United States. Our members are primary care clinicians who provide evidence-based midwifery care throughout the lifespan, with an emphasis on pregnancy, childbirth, gynecologic, and reproductive health care. ACIMM works to promote equity, diversity, and inclusion throughout the midwifery profession and across the care continuum to ensure better healthcare outcomes for the people that we serve. So I'm sure you are so aware of that the United States is continuing to face a maternity care provider shortage in rural and underserved areas. And the shortage of OBGYNs, coupled with a steady decline in primary care physicians, reinforces the need to increase the number of full scope maternity care providers. Access to care provided by certified nurse midwives and certified midwives has been shown to produce high quality outcomes, including spontaneous labor, vaginal birth, and increased rates of breastfeeding. And people who receive midwifery care have reported high rates of satisfaction with the care. Midwifery is underutilized in the United States. We attend 10.3% of births, and we could be doing so much more if there were more midwives. And here's the focus of our organization right now. There are almost 14,000 CNMs and CMs in the US, which is an increase of only 2,800 since 2015. To meet the demand for reproductive and sexual health care services, ACIMM has been investing in a workforce study and increasing access and funding for midwifery education. The Bureau of Labor Statistics doesn't single out midwifery as a profession, so it's hard to accurately count how many CNMs and CMs are providing care, as well as where they are. ACIMM has been doing a workforce study based on publicly available data, as well as information collected by the American Midwifery Certification Board. We have also been surveying and interviewing students, midwives, and people who have left the profession. The workforce study has 3 prongs: to describe the workforce and create state-specific models for increasing the number of midwives, to describe barriers and facilitators to entry to practice to midwifery, and to describe reasons for attrition and create recommendations for addressing why 30% of CNMs and CMs leave clinical practice within the first 5-year certification cycle. So like other professionals, we have a fairly high attrition rate. We can figure out how many midwives we need where, but that doesn't tell us how we can educate more. We also must address the fact that the majority of CNMs and CMs are white, and we don't match the population that we serve. We started the Access to Equity in Midwifery Education and Care project to try to increase recruitment, retention, and graduation of midwives of color. We have a dual approach, working to improve existing programs, as well as reaching out to historically Black colleges and universities to facilitate discussions about the benefit of midwifery and to generate interest in starting education programs. We identified some next steps for this project. We're developing an equity in midwifery education report card, which will be part of the required annual reporting for program accreditation. We realize there's an unmet need for cross-institutional programs with peer support groups, mentoring, and community building. If we would like to see more Black and Brown faculty, we have to support them to become directors of education programs. There's a need for professional development to increase the skill set in accreditation, budgeting, grants, curricular development, and management. And we're going to continue to do our outreach to HBCUs because they have created an education model that supports their students and fosters success. ACIMM has also been working to increase access to midwifery care through pursuing government funding for midwifery education. So in every department, we're really trying to scale up our workforce. ACIMM has worked with Congress to secure over $25 million in federal grant funding for midwifery education through the annual appropriations process. This is setting a precedent with a larger goal of establishing a permanent funding stream to increase the number of nationally certified midwives in the US via passage of the Midwives for Maximizing Optimal Maternity Services Act. And this bipartisan Midwives for Moms was reintroduced in the House and the Senate in this June. This bill would establish new funding streams for midwifery education. It creates a midwifery expansion program for accredited midwifery education programs that educate CNM, CM, and CPM students. The bill will help mainstream midwifery in the United States in a way it is not yet mainstreamed. And HRSA, once this bill passes, may provide grants to midwifery education programs for direct support of students, establishment or expansion of accredited midwifery programs, providing support for increasing the number of preceptors at clinical training sites, which is the greatest limitation for expanding the midwifery workforce, lack of access to clinical sites. And prioritization will be given to programs that seek to increase racial and ethnic representation and those who agree to serve in health provider shortage areas. So midwifery is also now a part of the Black Maternal Omnibus Act of 2023. We worked with Representative Underwood's office to draft and review the new Perinatal Workforce Act language, where there is now funding for midwifery education as part of the Black Omnibus as well. And finally, I want to mention ACIMM's participation as a partner with ACOG and other organizations on the AIMM project. It's an important piece of what we do. Midwives participate in bundle development and revision. We hold space for physiologic birth. We represent core midwifery values and other professional values. Listen to people. We are glad to be in the room where things are happening. We co-create guidelines. We add midwifery voice to the national conversation. We're a part of systems level change. And finally, we participate in implementation, revision, and provider education as part of the AIMM project. So in conclusion, midwifery in the US is small, but we're mighty. And we're really working to scale up so there can be more access to midwifery care and midwifery-led care. And so in terms of aligning with this committee, we have very similar interests and would be happy to align on anything that we can be of assistance with. Thanks.
Thank you so much, Karen. And now we'll go to Deborah.
Morning. Thank you so much to this committee for inviting the American Academy of Pediatrics to present our perspective on how we can work together on infant morbidity as well as infant mortality, as well as the maternal morbidity and mortality component. Next
Deborah,
slide.
can I ask you to get a little closer to the microphone? It'll just pull it up just as close to you as you can. Thank you.
Like try to eat it.
Close.
Thank you, Belinda. And thank you again for inviting the American Academy of Pediatrics to present to this committee. Next slide, please. So the American Academy of Pediatrics, I know everyone else started with an overview of what their organization is. The American Academy of Pediatrics was founded in 1930. So we've been around for a while, and we really have been established to address the unique needs of infants and children, and including their mothers. The mission of the American Academy of Pediatrics is to attain optimal physical, mental, and social health and well-being for all infants, children, adolescents, and young adults. We have over 67,000 members, both in the United States and globally. We have chapters in every state, and in some of the larger states, we have more than one chapter. We also have chapters within Canada. We have a component of committees, councils, and sections that address a wide variety of child health topics, clinical practice, specialty care, community pediatrics, and others. The American Academy of Pediatrics approach is grounded in public health. We have primary, secondary, and tertiary prevention, and I'd like to highlight through this presentation what the AAP is doing in these areas, not only to support clinical practice, community activities, but more importantly, state and national advocacy. In terms of tertiary prevention, for instance, it's about the care of the preterm infants once they have been born. We have many things on secondary prevention, screening for diseases and problems, and importantly, the primary prevention. What interventions do we have to prevent disease, such as vaccinations and injury prevention? How does the AAP affect change? Through our policy, our education, programs, research, and advocacy. And as we've heard others say, the utmost importance for the Academy is our strategic priority on equity, how to best address the social and structural determinants of health. And AAP has an essential policy on the impact of racism on child and adolescent health, and that was published in 2019. And that has been embedded in all of the work that we do in terms of revising our clinical practice guidelines, making sure that race-based medicine is eliminated from clinical practice guidelines, as well as in our programmatic and advocacy work. I think the most important thing that the Academy does do is its partnerships with families and communities. We encourage and support pediatric providers to work with our communities and listen to them to see what they need. Next slide, please. So I put this up here not to educate all of us on infant mortality data, but to recognize that congenital malformations, preterm birth and low birth weight, sudden infant death syndrome, unintentional injuries, and maternal complications are the 5 leading causes of infant mortality in 2020. The asterisk is there not because it's in the top 5, but about half of the child abuse fatalities were in children under the age of 1. And this is the data from 2021. And the Academy has efforts in all of these areas. That work has been generated by AAP subject matter experts, developed with support from federal agencies, strengthened through partnerships with national, state, and community entities, such as the ones that sit here with me today. We want to give specific acknowledgement to our federal partners at HRSA and CDC for their invaluable and longstanding collaborations with the Academy. I apologize that I cannot address all of the important work the Academy is doing in this brief overview, but direct you to the Academy's website, both the public-facing one on healthychildren.org, which contains our parent as family-facing information, as well as aap.org. And happy to address any specific topics in the panel discussion. Next slide, please. Bright Futures. I'm sure all of you have heard about Bright Futures. It's really our quintessential guidance on health promotion and prevention, and it contains a lot on primary and secondary prevention. It is supported in part by HRSA and the Maternal Child Health Bureau. They provide age-specific theory-based and evidence-driven guidance for all preventive care screenings and health supervision. And I point out this role of Bright Futures in preventing infant mortality and addressing infant morbidity through the one prenatal visit. I think there should be more with the pediatrician to establish a medical home, and then a minimum of 9 well-child visits through the time a child is 15 months of age. And these provide important touch points to provide screening and parenting education. Next slide, please. So when we talk about clinical care a little bit, many of the individuals who are on this panel talked about the initiatives they have in terms of the maternal side of things. This is about the neonatal side of things. The AAP has a policy statement on levels of neonatal care. It's a review of the data that supports tiered provision of neonatal care and the need for nationally consistent standards of care to improve neonatal outcomes. It supports a well-defined regional system of perinatal care and designation levels. First, it's a basis for comparison of health outcomes. So heard this committee talk about data. So there's a wide collection of data that occurs at the different levels of care, as well as on resource use, apologies, and healthcare costs. It provides standardized nomenclature for public health, uniform definitions for pediatricians and other healthcare professionals providing neonatal care, and a foundation for consistent standards of services for institutions, state health departments, and state, regional, and national organizations focused on the improvement of neonatal care. We have a companion standards for levels of neonatal care for levels 2, 3, and 4, and it's a complementary implementation tool. And then lastly, we have a NICU verification program, which helps establish and implement risk-appropriate neonatal care through standards that improve neonatal outcomes. And we really want to ensure that every infant receives the care in a facility with the personnel and resources appropriate for newborn's needs and condition. And as others around the table have spoken about, the needs to make sure that we have a competent workforce and the appropriate capacity and capability within that workforce. Next slide, please. I know we've heard a lot about breastfeeding and chest feeding, and we do know that breastfeeding is associated with a significant reduction in infant mortality. The AAP has policy, education, and leadership around this important topic. In 2022, we updated our landmark breastfeeding policy, breastfeeding the use of human milk. We have an important policy on paid family medical leave, so addressing those upstream causes to support families in establishing successful breastfeeding. And we also have a policy on the pediatrician's role in decreasing racial disparities in breastfeeding. So again, a common topic that we heard here, the importance of breastfeeding and chest feeding, especially in our populations of colors. We also have a free online breastfeeding curriculum developed in conjunction with the CDC. And we also have educational webinars. And most importantly, we have in-person breastfeeding education at our national conference. And we have leadership across the nation in having a breastfeeding champion in every US state to promote and support local breastfeeding initiatives. Next slide, please. Immunizations. I won't go a lot into this. We all recognize the importance of immunizations, but what we also need to recognize is that the value of immunizations has been attacked, and the Academy is doing everything it possibly can to assure that individuals, parents, and others recognize not only the importance of vaccines, but the safety of vaccines and the role that they've played in preventing maternal mortality and infant mortality throughout the ages. We have information in our Red Book online, communication guides, and again, chapter immunization representatives. How does the National Academy help affect change at the local level? Next slide, please. Sudden infant death syndrome, again, a leading cause of death. And we do know that there are disparities amongst our populations in terms of sudden unexpected infant death and SIDS. We have a landmark policy again in 2022 on recommendations for reducing infant deaths in the sleep environment. And then we have a programmatic efforts, again, funded by the Maternal Child Health Bureau, that aims to reduce the overall rates of SUID and reduce racial and ethnic disparities. We have a website where we've developed a number of safe infant sleep resources. We promote fatality review through collaborations through the Child Death Review and the Fetal and Infant Mortality Review. And we have a national collaborative for safe infant sleep. Next slide, please. I really want to dig into something that I've heard a bit about here when we talk about screening for perinatal depression. But what's more important is early relational health. So it's the flip side of perinatal depression. How can we actually build those strong bonds between the mother and the infant in terms of making sure that relational health is the grounding piece of how we better support infants as well as their mothers. We recognize that family relationships promote resilience and positive health and mental health outcomes for both the caregivers and the children. Relationships should be safe, meaning the relationships are free of physical or psychological harm. We need to know that children believe that the caregivers will protect them. They need to be stable, that the adult is dependably there for the child, and children believe that their caregivers will be able to meet their needs. And nurturing. The child's physical, emotional, and developmental needs are sensitively and consistently met, and children believe their caregivers will use warmth and clear expectations to foster their development. This is really grounded in a family-centered two-generation approach, and it's needed to really promote the optimal growth and development. The founders of the AAP recognized the interconnection between maternal health and well-being and the health of their children, and that thread has been carried through the 93 years of existence of the American Academy of Pediatrics. Next slide, please. Trauma and infant mortality. I mentioned at the beginning that half of the child fatalities secondary to abuse occur in infants. We recognize that adverse childhood experience literature has demonstrated the effects of childhood adversity on adult health. We recognize that systemic racism and racial trauma affect the health and well-being of mothers, and there is strong evidence that is linked to infant mortality. We recognize that caregivers who have experienced trauma may also experience substance use disorders, mental health concerns, and continued adversity. So those linkages to trauma early in life carry through into adult challenges. And we understand that this may lead to child abuse, neglect, and unfortunately, infant death. And we also recognize that trauma can impact the ability to meet a child's physical and emotional needs. And this is a term that we refer to as disrupted caregiving. The Academy has many programmatic and policy and tools and resources to support not only awareness, but also attention and improvement in relational health. And the next slides kind of highlight that. So the AAP supports pediatricians in assessing and supporting the mental health of maternal caregivers. These are just some questions that are embedded in Bright Futures and our anticipatory guidance. Has anything scary happened to you or your child? What are you doing to take care of yourself? And I know we've talked a lot about your child's health, but we want to talk to you about a person. Brief interventions. We have tools and resources to help promote the strength of the caregiver-child relationship, encourage understanding and responding to child's behavior, encourage reading and talking to the child, simple things, routines for security, sleep, diet, exercise, stress, and relief. We want to encourage mothers as well as families to promote realistic expectations. All of us live within the barrage of social media and perfect pictures. That's not what reality really is. And we have a whole campaign on social media and the effect on the adolescent brain. And I would have to say that the work that we're doing is to make sure that people are realistic about what pregnancy is all about what the delivery is all about, and what caring for an infant and a child and an adolescent is all about. And we also encourage social connections and connection to community resources. Next slide, please. So maternal and relational health at the AAP, it aligns with our strategic priorities. We're building capacity, not only in maternal health and well-being, perinatal mental health. Someone mentioned fetal alcohol spectrum disorders. We do recognize when we talk about birth defects that exposure to alcohol is preventable. And we do know that exposure to alcohol is a preventable cause of a birth defect. Maternal infant health and opioid use. Some of the individuals here talked about substance use and the effect on ability for a mother to care for her infant, as well as other work that we do in terms of supporting our chapters through our early childhood chapter champions. I think the next slide is just a list of additional resources. Next slide. And I won't go into further detail. And I think, next slide. Again, a number of different programs. We put that out there for you all to look at. And there are links on aap.org. And I think that's the end of my presentation. Thank you. I'm more than happy to answer questions.
Thank you all so very much. We appreciate those informative presentations. Now we will open it up for questions, because I know we have a few. Yes, Marie. Mhm.
Thank you all for this great work that you're doing all around and nationally. I appreciate a lot of the overlap that was discussed in your presentations, what your national organizations are working in partnership. Like you said, many of your organizations are sister organizations when it comes to supporting maternal health. One organization I haven't seen, and I'd love to hear what you're doing, is with the Academy of Family Physicians. Family doctors see over 50% of all ambulatory visits. In rural settings have the highest presence in rural settings compared to our specialist colleagues, and in the health center setting are an integral role as well when it comes to general primary care, but certainly with maternal care as well. Had a great pleasure of working together with ACOG to develop the advanced life support for obstetrics, and now working with the fourth trimester care work that you're doing, and had a pleasure working with your colleague at AAP, Fan Tate, with some great projects that we worked in alignment. So I would love to hear, what are some advocacy areas that you're cross-pollinating with your specialty colleagues as we're trying to touch on maternity, infant mortality. And the second question I had, slightly related to that, is innovative ways, and I think this is more related for NAC. In community health centers, and particularly federally qualified health centers, we get just a specific amount of reimbursement for all visits. Only exception that I know of is with annual wellness visits with Medicare patients. You get a little bit more reimbursement for annual wellness visits in a health center setting. Has there been any advocacy on the maternal side to have a parallel type of reimbursement for maternity care, like an annual wellness visit equivalent that would get a higher reimbursement rate in a federally qualified health center setting? And similarly, with the problem of finding that date of delivery, would there be a possibility to consider something like a transition of care management type visit postpartum that requires access to delivery information within that first 3 days of delivery? Has there been anything to that level of advocacy to try to encourage and incentivize this kind of work? So maybe the latter would be an easier question to start with, and then I'd love to hear about other partnerships.
Sure. So I'll jump on the latter as the informaticist here. Yeah. So, the federal government already requires that inpatient facilities provide a discharge or ADT notification within 72 hours. But we know that that's really, not remotely close to 100% in terms of transmission. Another challenge, though, is that many organizations can only take ADT messages in a sort of semi or unstructured format. So, for example, you might get basically the equivalent of an electronic fax. That information can't be taken into the EHR. And that's part of the reason I mentioned the US CDI, right? The federal standards for what concepts electronic health records have to support. So given that there's no standardized code or approach to structuring the data in the birth encounter, there's no way of easily mapping that back into an EHR, and there's no actually guarantee that there's even a target place for that information to go in the electronic health record. Many organizations will create sort of a customized field or a place to put that stuff, but it doesn't mean that two systems, even from the same vendor, could talk to each other and recognize that. So it's a bit of a technical challenge. I think, more accountability from CMS on, an actual follow-up action that occurs in a transition between the inpatient and outpatient facility is really important. And I think also a notification that goes to the outpatient organization when the person hits the hospital door also has the potential to allow better coordination during the birth episode. To speak to the reimbursement piece, I'm obviously not the policy side of NAC here, but one of the things I can say is traditionally I know that health centers have struggled because in most federal regulatory policies, health centers have to be opted in to any new programming. So frequently it's sort of totally unintentional that, congressional leaders and their aides will not include that language because they're not sort of aware of it or tracking it. And so then NAC spends a great deal of sort of advocacy effort just trying to correct those omissions. I think the idea of doing a sort of proactive program is really smart and important. And when we talk about transitions of care, I know some health centers are also really looking into the postpartum transition of care. As a primary care provider, I can't think of any time I've ever actually gotten a transfer from a primary obstetric person to hey, your patient is back. This is what happened. I don't get any of that handoff either. And I think, in terms of thinking about the long-term health of the patient, if they had gestational diabetes, if they had hypertension during pregnancy, those things are important because they change the way I approach the patient in their postpartum life, right? But certainly the risk in the peripartum setting is really important. And the MMRC data shows that more than 50% of deaths happen in the postpartum period, right? The 7 to 42 days, and then almost a quarter still in the 42 days to a year. So I think the amount of attention we're paying to the birth encounters is probably doing us a disservice because we're not focused on that period where actually now most of the bad outcomes are happening. So I think that if HRSA or anyone else would like to go in on that proposal to sort of raise the bar on both the reimbursement and on sort of the accountability of that transition, I think we'd be really interested in that. And I'll just say our CMO is a family physician who became he did primarily obstetric care for migrant health workers in California, became the CEO of their health center, and he could probably speak much better to our AFP collaboration. But I think from the health center perspective, we think of sort of the same relationship that we have with our midwives and with our family docs and our obstetricians.
So from the Academy's perspective, we work very closely with our colleagues at AAFP. We have representatives from your Academy sitting on many of our committees, councils, and sections. And most importantly, they're well embedded within the work that we do around Bright Futures. And we really truly appreciate that partnership. So thank you for bringing that up.
I was going to say ditto to what Dr. Waldron just said. We're also incredibly fortunate to have engagement with AAFP. As you know, at ACOG, I can speak specifically to the engagement in the departments that I support, which is the AIM program, as well as the broader quality and safety work. In AIM, AAFP is a contracted partner, as are other folks here at the table. They are engaged in development of all of our resources. They were integral in the development of the OB readiness, emergency readiness resource kit, and actually led the way in some of that. We recognize that OBGYNs weren't the ones to talk about how to provide care in areas where there are not obstetrics care. So that is a wonderful collaboration, and I have some folks at AFP on speed dial. So our collaboration in rural space, I think, is just going to grow that more and more, including the ALSO program. We actually also collaborate in that way when we work with Indian Health Services and provide Indigenous health training, because we also recognize those providers are actively engaged in obstetric care. Just a word about the payer. I am not in that department, but I will tell you my background's in policy. And it's a priority area for ACOG, working in the health economics department to specifically address reimbursement around prenatal postpartum care across the continuum, and to recognize that bundled reimbursement does not meet the diverse needs of patients. And as we add in, very rightfully, the expectation that providers address and screen for social and structural drivers of health, we have to make sure they're being reimbursed in a way that allows them to do it effectively and to build partnerships effectively that are going to really augment that work.
Well, thank you all. Any other questions in the room? And then virtually? Yes, Dave.
Sure. And for Karen, for the ACIMM, I really appreciate too what you're doing with the historic Black colleges and universities. One thing we've found in the work, I work with midwives and doulas and whatnot in Minnesota, is that if we can also get to high schools in our neighborhood, we live in inner city Minneapolis, it's a great way of sort of a pathway of interesting students who say, hey, I think doula services, or maybe just working at a birth center or working in a maternity care setting. And then they go from that, and then they think about, I could be a nurse. And then after that, they say, I really would love to be a midwife. So I would also recommend just considering doing some outreach into schools and communities that way. And another thing too, all of your presentations were great. And Julia, I'm a person who, I did my National Health Service Corps service back before, while we were still using paper charts. So a long time ago. But I really appreciate the fourth trimester work that you're doing with CDC. And as we were talking before, we're trying to figure out, I mean, we can come up with a whole bunch of recommendations, but a recommendation that has an impact is that fourth trimester work. And I truly believe that what you're doing could be transferred into Medicaid programs in every state. And they're also, commercial insurers, they should know about that. And I do know that the data transfer, and OCHIN is, to remind me, that's kind of the Epic-based EHR. Right. And just being able to, put the pressure on us at the office of the national coordinator to just say, you need to insist that data flows, because that's what it takes. But anyway, the work that they're doing with CDC on the fourth trimester is very impressive.
I just wanted to make a quick comment, because I wanted to build on that. So with the respect to diversification of the workforce, I appreciate the work with the HBCUs as well. A1 is doing some work with HBCUs also, and the comments around going upstream from a pathway perspective. One of the areas I think we should also continue to focus on for non-traditional students is work with community colleges as well. So just putting that out there for consideration.
I just wanted to, I'm a longtime member of A1, and I wanted to compliment Mr. Webb on his presentation about trying to map out the contribution of nursing care. And I don't know that many people don't know that most of nursing care services is a part of the hospital room costs. And many years ago, when I was an active duty Army nurse, we did a very in-depth study on workload management, where we were looking at nursing staffing and patient acuity. So I think it's another part of the puzzle in terms of maternity care and the health disparity issues. So important work.
This was really excellent. Thank you to all the panelists. And I'll just say, Marie, that was our miss in not including AAFP. We kind of try to think of every possible, I think, association. And I'm not sure how we missed that, but we will, Belinda and I were saying we'd love to obviously get them at the next meeting. The one group we also had invited but couldn't make it was the National Association of Community Health Workers. So just wanted everyone to know we did try there, and they unfortunately couldn't join, but we are going to try again at another meeting. I know, Karen, you mentioned, or I think it was you, the Bureau of Labor, and I just wanted to share that we have an ex officio member coming from the U.S. Department of Labor, their Women's Bureau. So for a lot of these workforce issues, we are excited to have a new member that will be able to join, and I hope we can introduce her at the next committee meeting.
Yes, Kate.
So my question is, who can we recruit from all of you to work on the work groups we're talking about? You know, and I'm not, I mean, Julia, man, you would be great for the data workforce. You know, Mr. Webb, you would be fantastic for our kind of commitment to looking at racial disparities and what will work. You know, I could say something for each of you. Of course, Christy, I know well, but anyway, wouldn't it be great, you know, to incorporate some of them
Please
in the
know we
groups?
will be reaching out to them. They didn't just get an invite to come and share. We could plan to stay engaged. So thanks for the reminder, Kate. And I think we have one hand up, Sherry. One of our members is participating virtually, and Sherry will be our last question.
Yes, thank you very much. And thank you so much to the panelists. I agree with Maria. This was beautifully put together and you all presented so effectively, and it was very easy to see overlaps. And I would like to spotlight something that Dr. Waldron mentioned, and that was the establishment of the infant's medical home through a process of a Unfortunately, our health system is very siloed. It's really challenging to figure out how we can achieve this Bright Futures recommendation that expectant parents will engage with the pediatric practice to establish their baby's health care before the delivery of the baby. Families often are thinking more about where they're going to get their child care than where their newborn baby is going to get their medical care. I would like to propose that the connection between obstetrics and pediatrics, when that new family comes to their pediatrician, that is also maternal health care as well. And I can base that on a personal story. As a general pediatrician, I saw a mom and her newborn in clinic 3 days after delivery. And fortunately, the baby was healthy, doing well. However, the mother was febrile, looked very ill. And through that clinic visit, she was transported to the hospital and admitted and treated for sepsis. That's every encounter in pediatrics is an opportunity to see the family and as Dr. Waldron also mentioned, the importance of the caregiver's health and well-being very much impacts the infant and the young child. So we really in pediatrics strongly believe in the dyadic work that we do. And we mentioned also that half of deaths due to child abuse are in infancy, and that violence does not begin at the moment of birth of a child. It usually pre-exists the birth of that child. So most of reports of suspected child abuse and neglect come from professionals, including pediatricians. And that is also an opportunity for assuring the health and well-being of the mother when they're coming to their pediatric visit. So I really would like to ask the panelists, how can we break down the silo, build a bridge between obstetrics and pediatrics, and promote the standard that assures that a baby has a medical home through a prenatal visit with a pediatrician prior to birth? Thank you.
No, thank you, Sherry, and we'll see who wants to respond.
So I think community health centers have that a little bit built in. I will throw out a word of caution. We've been hearing reports that hospital-based systems are trying to push pediatric patients out of the health center to their own hospital-based pediatric practices, and that's probably a threat So that sort of community-based care, as well as those coordination activities where mom and baby's records are being linked. That's another important area. How do we connect those two things so that we can look for those patterns, a history of domestic violence, a history or a screening for depression, not getting back to mom, even if it's happening in pediatrics office. So I think, building on the comment from earlier about having these models of care that actually combine those two pieces at the same time. I think, especially for the patients at high risk, the patients who come from vulnerable social situations, that's going to lead to much better outcomes. And I would encourage folks to work with health centers.
And I just want to add a few thoughts. With a pretty broad use of group prenatal care of different kinds, it would be a great opportunity to have a pediatric provider attend prenatal group care, and also to have family dyadic care in the group setting continue postpartum, shifting from the OB, midwife team to the family practice pediatric team afterwards, where the community stays intact and the new providers can follow the dyad through time. It does exist and should be more widely done.
Thank you for that. So the American Academy of Pediatrics does have a policy statement on the importance of the prenatal visit, and it outlines many of the things that were just discussed here. We do know that when the umbilical cord is cut, it does not sever the tie between the mother and the infant, and that does need to continue. It happens preconception, it happens during the pregnancy, and most importantly, after delivery. So we would encourage any type of ability for the prenatal visit to occur, as well as that establishment of care. One of the things the Academy works on is transition of care from adolescents to adult providers, but we need to work a little bit better on assuring that transition and continuation of the care continuum after an infant is born. So we'd love to work on that, because again, that relational health and that dyadic care that Dr. Alderman pointed out is extremely important.
Well, thank you all so very much. Please join me in thanking this awesome panel today. And thank you all again. So we will take a lunch break now. We do need to get back by 12:30 though, so I know it's a little short, but we should be used to that by now. Okay. Thank you, but 12:30. So hopefully everyone has had a good lunch. If you are still eating, please continue to do so. We know we didn't give a whole lot of time for that for this meeting. We'll try to do better next time. We're now going to move into our next session. And our next session is, again, we're bringing together partners. These partners are specifically partners in the field that are going to focus on some policy areas that they're working on. And keep in mind that we continue to think about ways for alignment. So I think all of our panelists this time are virtual. So we're just going to do a quick check-in. So we are happy to have with us this afternoon, Jennifer Moore. Jennifer is the founding executive director for the Institute for Medicaid Innovation. Jennifer, do we have you? We have your slides. I'm thinking you're there. After Jennifer, we'll have Tara Johnson. Tara is the director for a health program for the National Conference of State Legislators. So I'm thinking Tara is on as well. And after Tara, we'll have Brittany Roy. And Brittany is the program director on the public health front for the National Governors Association. So we will go in that order, and we will start with Jennifer. So thank you, Jennifer.
Thank you. I'm really excited to be here. Thank you for the invitation to share more about the work that we're leading aligned with the work of the committee. As a former committee member, I can appreciate how important these presentations can be. We've been given 5 minutes per presentation, so I'm going to go as quickly as possible. But you'll see as I go through the slides that they're jam-packed with information so that you can refer to them after. Next slide, please. And next slide. So the Institute for Medicaid Innovation is a 501c3 national nonprofit, nonpartisan research policy and community power building organization. We're located here in Washington, D.C. We center our work around improving the lives of Medicaid enrollees, focusing specifically on individuals, families, and communities. We're known for partnering with all types of Medicaid stakeholders and partners, including state Medicaid agencies, Medicaid health plans, provider groups, including those who are on the last panel, and individuals with lived experience and those in the community. Next slide. We have a large portfolio of work. Our core topics are represented in the circles around the large circle, ranging from behavioral health, disparities in equity, child health, and women and gender health. And in the center represents the center circle, or middle circle represents the type of deliverables, everything from qualitative and qualitative research studies that are published in JAMA and Health Affairs to our national learning series and learning collaboratives. Next slide. And I just have to ground us all that while we get excited about the statistics and the data, that's truly when you love someone, and that is when it becomes very real. As a former Medicaid enrollee myself for 8 years as a child and 5 years as an adult, I know how important this program is to the lives of individuals, families, and communities in this country. Next slide. So I'm going to share with you some perinatal and maternal health findings through our work. I'm going to touch very high level, go to our website to get more information, and then I'm going to dig into a recent survey and focus group that we conducted that will be helpful in informing your work. Next slide. So this is a very small snapshot of a comprehensive portfolio of work that we lead in maternal, perinatal, and reproductive health, including resources in maternal mortality and morbidity, maternal mental health, high-value evidence-based maternal models of care, including doulas and midwifery-led models of care, and other maternal health priorities. All of these resources are available on our website, and we have even more categories of information. We are known as the national hub for maternal child health in Medicaid, and probably have a resource on every topic you could be looking for. Next slide. So the one that I wanted to really dive into in more depth, of which you received in advance of today's meeting, is an issue brief that we released on identifying priority topics in Medicaid specific to women, gender, and maternal health. We surveyed federal policymakers, state policymakers, Medicaid health plans, national subject matter experts, and also individuals with lived experience in those working in the community. Next slide. So as you can see from this table, across the board, regardless of the stakeholder type, whether it's federal policymaker, state policymaker, Medicaid health plan, or subject matter expert, you'll see that maternal mental health ranked #1 amongst all of these groups. From there, there's some close alignment, but some differences that exist. But truly, doulas and perinatal community health workers, sexual and reproductive health, and prenatal to 3 rose to the top. I'll also add that although midwifery-led models of care was ranked at #8, for the other stakeholders, the federal policymakers identified midwifery-led models as #2. I think in the grand scheme of things, as we had conversations around these topics, all of them were forefront in their mind and of great interest to their work. However, in the process of ranking, someone has to be 8 and someone gets to be 1. So all of these were very important, and I don't want anyone to walk away from these findings thinking that only maternal mental health was #1. Next slide. So as I shared, we also surveyed individuals with lived experience, and those represent individuals with current or past Medicaid health insurance coverage, and also members of the community-based workers such as doulas, community health workers. And they shared with us, unranked, their priority topics, including chronic conditions, sexual and reproductive justice, violence, caregiver role, housing, substance use disorder, criminal justice system to address unmet behavioral mental health needs, delayed care, and community-based maternal health, which include midwifery-led models of care and doulas. It's also worth noting that inside this table, we provided some contextual information. This was gleaned from a focus group. Given the incredible information that they provided during the survey, we scheduled an ad hoc focus group just with individuals with lived experience and community-based workers. And you'll see in the slide quotes in addition to contextual information. The next slide, it makes it a little bit bigger, so it's easier for you to see some of the core quotes. There were so many quotes, it was hard to pick ones for the release, but these really do capture the high level sentiments of the group. I also want to note that there were two other takeaways that are outlined in this issue brief. One being that they didn't like the term social determinants of health. They felt that it was jargon that was created by individuals who did not have experience with challenges with social needs, and asked that we start using and naming the social need, such as housing, interpersonal violence, instead of the term social determinants of health. They also did not like the term equity, recognizing that centers whiteness and white supremacy, setting white outcomes as the benchmark or the standard, and instead preferred the word justice. So as you could see from the previous slide, they identified sexual and reproductive justice. They talked about birth justice, mental health justice, and just want to leave that with you as you consider ways of moving forward as a committee. Next slide. We also recently released a national environmental scan identifying innovation in perinatal and child health, specifically in Medicaid. And this work was funded through the Pritzker Foundation and provided us an opportunity to get a sense of the landscape in the US and where that innovation and best practices are landing. It also gave us insight into what states are prioritizing. No surprise, most states were either in the initial stages or pilot stages of a doula and perinatal community health worker program. Home visiting programs was also very prevalent, along with dyadic care, thinking about the pregnant postpartum individual along with child or children in the home. And then, of course, mental health and substance use disorder arose to the top. This is a resource that you can also access. It's a comprehensive report outlining many best practices and innovative initiatives that serve as a roadmap in many ways in what's next and what our people are leading. Next slide. So I hope I didn't go over my 5 minutes. I tried to talk as fast as I could and don't want to take away from my other colleagues who are presenting today, but you can certainly find more information on our website, including the references and resources I mentioned today. If you have any problems accessing them, let me know. I'm happy to make sure that you can get them. And so with that, I will defer to the moderator to transition to the next speaker.
Thank you, Jennifer. Can you stay around in case there are questions at the end?
Absolutely.
Thank you. So now we'll go over to Tara Johnson. Or Tara, I may be mispronouncing your names, so please forgive me.
No problem at all. Thank you very much, Chair Pettiford, and for the committee for inviting me to speak with you today. My name is Tara Johnson, and I direct the health program at the National Conference of State Legislatures. So today I will share with you how state legislators, including NCSL's Maternal and Child Health Fellows, have focused on maternal and infant health improvement in the last few years and what the legislative trends are. Next slide, please. First off, it's important that you know that NCSL is a bipartisan membership organization serving the 7,386 state legislators and several, well, tens of thousands of legislative staff in the 50 states, Washington, D.C., and the U.S. territories. Our organization promotes policy innovation and communication between state legislatures, among many other things. Next slide, please. So NCSL's Maternal and Child Health Fellows Program is designed to support legislators who are experienced or emerging leaders on maternal and child health issues. These fellows learn from peers and from health experts while discussing maternal and child health priorities and policies that are being considered in state legislatures across the country. So far, we've had 4 cohorts consisting in total of 96 state legislators and 8 legislative staff from 41 states and the US Virgin Islands. These fellows come to us with a variety of different backgrounds and professions. So former fellows include pediatricians, lawyers, educators, farmers, and business owners. They hold leadership positions in their legislatures, such as assistant majority leaders, Senate president or pro tems, and chairs or vice chairs of health committees. So they're policymakers, and many of them have lived experience, and they hear regularly about the experiences of their constituents. We were able to hear about efforts that fellows were making in their states following their programs during an alumni meeting in December of 2022. We brought together former cohorts, and then we also had a 2023 cohort that met twice this year, both in January and in April. They did deeper dives into specific topics, and one topic that continues to rise to the top is maternal mortality and maternal health. We also covered priority issues around telehealth, insurance coverage for doulas, and postpartum Medicaid extension. Next slide, please. So as a part of this program, fellows are asked to create action plans. And so many of them did that for 2023. And these action plans are intended to provide a framework and support for legislators to help them accomplish whatever their legislative goals are. So some major themes that we saw from these action plans, as well as the research requests that we were receiving at NCSL, relate to several issues that were just mentioned by the previous speaker: the maternal health workforce, maternal mortality, specifically maternal mental health, infant mortality, and newborn screening. So we're seeing the maternal care workforce as really a top priorities among our members. Workforce across the board is a top priority for state legislators. And our fellows expressed specific interest in workforce solutions, such as expanding the use and coverage of doula services, reviewing scope of practice or licensing for midwives, and providing bias training for providers. In many cases, specifically mentioning the intention to improve birth outcomes and reduce maternal morbidity and mortality. Legislators are focusing on improving services and access to care related to reducing maternal mortality. And there's a specific focus for many of our members on rural communities. Fellows in particular were interested in reviewing the Maternal Mortality Review Committee reports in their states and meeting with their Title V directors. We're holding committee hearings on maternal mortality to receive more information about the specific data and information in their states. And as the previous speaker mentioned, state legislators are focused on maternal mental health and substance use disorder supports, including coverage for these services. And that is a priority for state legislators that we're continuing to hear. Now, while the focus primarily has been on maternal health in this last legislative session, we have seen efforts and a continued focus on infant mortality by way of educating parents and providers on substance use, on sudden unexpected infant death, and exploring ways to increase access to maternal and infant care in rural communities. And then lastly, one other trend that we've seen with our members is a focus on newborn screening panels and other screening processes, such as aligning with the RUSP and exploring future funding opportunities for screening programs. Next slide, please. So NCSL has tracked nearly 100 enacted bills in the last 2 sessions, specifically on infant and maternal mortality. There were a lot more that were introduced, but a few of the trends that we saw in terms of enacted bills really focus around access to care, maternal care workforce, awareness and education, and studies and committees. And again, there's also a priority within here and in other bills that we saw around maternal substance use disorder. As the largest single payer of pregnancy-related services, Medicaid certainly plays a significant role in maternity care coverage. And we've seen a lot of state interest in passing legislation around extending postpartum coverage for Medicaid to 12 months. Our members are becoming increasingly aware that a third of maternal deaths occur between 2 weeks and 1 year postpartum. And for example, this year we saw Mississippi and Nevada pass postpartum Medicaid extension for 12 months this legislative session. We've also seen an uptick in legislation around telehealth and providing telehealth options to increase care for the maternal population. Arkansas, for example, operates a telehealth program for high-risk pregnant women. And the programs consist of video conferencing with maternal and fetal medicine specialists. We've also seen New York now cover remote patient monitoring for prenatal and postpartum care if it's recommended by a physician. This again can increase access for those in areas with limited access to care. And as I mentioned earlier, the maternal health workforce is really a big focus area for our members and our fellows. For example, Louisiana requires insurers to cover state licensed midwifery care, including certified nurse midwives and certified professional midwives. Currently 10 states require Medicaid coverage, at least 10 states require Medicaid coverage for doula services, and at least 20 states are studying or piloting or implementing doula benefits in Medicaid. This has been an interesting area to watch. State legislators aren't always aware of what doulas are, but as they're getting more educated on the different types of workforce around maternal care, there's definitely been an uptick in legislation and an interest in learning more about doulas. A maternal and child health fellow this year sponsored legislation in Utah, for example, to increase insurance coverage for doula services in the public employees benefit and insurance program. Another interesting bill you might be interested in is the Delaware Omnibus bill that had several bills within it around workforce, which one requires implicit bias training and competency training for healthcare workers. They also enacted a law that provides access to doula and midwifery services for women in the Department of Corrections custody. States also are looking to reduce maternal and infant mortality by, again, raising awareness and educating constituents on the common causes of maternal and infant mortality. And this, again, can be informed by their review committees in the state. Oklahoma, for example, required perinatal providers to provide certain information to pregnant individuals, including educational resources, basic first aid, and information on cord blood banking and donation. Texas recognizes a specific day as fourth trimester care day, and Louisiana requires all hospitals and birthing centers to provide labor and delivery that provide labor and delivery to provide pregnant women and their families with information about perinatal mood and anxiety disorders, including symptoms and treatment available. So information on that so that the individuals and their families have information prior to discharge. We've also seen state legislatures be very interested in learning more, again, about their maternal mortality review committees, and some have been very engaged in the review committees specifically, and we've seen efforts in some states to require certain participation, membership, and duties of the committee. So for example, North Carolina now requires the committee to include community representation, and other states have modified their committees to require recommendations around racial disparities specifically. Next slide, please. So the three big takeaways I will leave with you. Number one, state legislators are doing a lot of work to promote maternal and infant health in a variety of ways. Two, maternal mortality and maternal health in particular is a priority area in state legislatures. And there are discussions happening in just about all 50 states, DC and the territories on maternal health. And then lastly, the number of bills and policies related to maternal workforce, access to care, and mental health have increased in the last year. So I want to thank you for your time today, and I'm happy to answer any questions or right now or through follow-up.
Thank you so much, Tara. If you will hold on, we're going to quickly go over to Brittany Roy. So thank you. We'll come back to you with questions.
Thank you. Can everyone hear me okay?
We can, thanks, Brittany.
Perfect. Okay, thank you all for this invitation and opportunity to speak with everyone on the line today. So my name is Brittany Roy and I serve as the Program Director for Public Health at the National Governors Association. NGA, as we call it, is the only bipartisan organization that serves 55 governors. So that's states and territories. And support looks like a variety of things, including technical assistance, an extra set of hands, if you will, policy creation, recommendations, convening power, et cetera. The maternal and child health portfolio at NGA, we've had this work since 1990, primarily through federal partnerships, and here more recently through what we like to call public-private partnerships. So this includes community-based organizations, think tanks, local and state government entities, as well as industry partners. Over the last year, so about 11 months, we have been working diligently on a CHAIRS initiative. So NGA every year alternates between a Republican governor or a Democratic governor, and they get to choose what their initiative will be for the year. We staff them and essentially host roundtables to collect policy recommendations. So this year, Governor Phil Murphy of New Jersey and First Lady Mrs. Tammy Murphy, their initiative is focusing on youth mental health and maternal and infant health. The public health team at NGA are the lead staffers on the maternal and infant health initiative. And essentially what we have done over the past year is convene with the support of governors regionally, roundtable discussions, like I mentioned before, through that convening power. Governor Murphy and Mrs. Murphy recognized that we had an issue and also recognized that we did not have a solution. And so we have gone all throughout the country and tapped many folks to help us think through where do we go next. And someone explained this very well. We've engaged enough, it is time to marry. So we are thinking about that next stage of engagement, right? And so a playbook will come out in about a month with all of these recommendations, and we call them practical recommendations and considerations because they have been essentially driven by governors. And then NGA will step in to help states think through implementation practices and policies. Just how do we move the landscape? Some of the things that we have heard over this past year from governors and their advisors are questions around public health infrastructure modernization. What does that look like for the maternal and child population? What does data modernization look like? And one of the things as well being, what does accountability look like? So we ask a lot of people, and now we are trying to figure out how do we hold the systems accountable, which is one of the reasons the public health team also carries the Medicaid portfolio. So how do we use the traditional payers and systems to bolster public health and improve the life of the MCH population? A little bit more about the MCH work at NGA. We work very closely with community-based organizations. We heard this loud and clear in our initial brainstorming session, nothing for us without us. And so we sat down with various experts in this space to say, how do we think through this? A lot of it we did not know, some we had heard. So this is more engagement with communities of color, so Black, Hispanic, and the part that we are getting better at and have put a lot of attention to are American Indian and Alaskan Native populations, the indigenous populations, and where do we go and how do we move the needle forward. In terms of the accountability piece, reaching out across multiple sectors to help us think through what does system reform look like, hearing things from states in terms of, the public health emergency has now ended. But where do we go from here? Where are the lessons learned from the COVID-19 pandemic that we can carry forward? How do we get that support? This also looks like working with our partners at NCSL to hear and listen what's happened at the legislative branch, as well as our partners at HHS to see what is happening at the federal level and to determine how we support the governors as they work to improve lives and improve health outcomes. And so I know we only had 5 minutes, so I want to stop there and happy to take questions.
Thank you so much, Brittany. We're going to open it up for questions now to see if anyone has any questions, either virtually or here in the room. Any questions? This may be the effect of right after lunch. So we're going to go with any questions. I know, Brittany, this is Belinda. I know you mentioned something about that the leadership rotates between the National Governors Association, and then you said something about they select a priority each year. I just want to make sure I understood you correctly. So how do they actually utilize that priority once it's selected? Do the other governors join in and say we are supportive of it as well, or do they still have options?
So they have options, which is why this roadmap is so important, because we're vetting it with all 55. It is actually out with the advisors and the policy directors right now to make sure we're tracking. But the governors do work to gain support. So we've been hosted by Governor Cox in Utah, Governor Whitmer in Michigan, Governor Shapiro in Pennsylvania, and we'll wrap up in New Jersey next month, where we'll have about 46 governors in attendance, and we will essentially lay out this playbook that has been vetted. And the other thing I will emphasize with being bipartisan, contrary to what we see on TV sometimes, they all play well together in the sandbox, if you will. And so we lean on that for them to tell us what will work, what will not work, what is operational, and really working to trickle information up, if you will, to the federal government on just what's practical for states.
Thank you so much, and thank you for reiterating the fact that they do play nice in the sand. We'll probably do better if we don't watch as much news, much TV. Thank you. Any others with questions or comments?
I'll just make a comment, Linda. Thank you all for your presentations. Jennifer, yours might have been burning because all yesterday and today we've been talking about innovations, particularly through Medicaid and that kind of thing, and what we're going to be canvassing for these priority areas that we're thinking about. What's out there that's working, and I think your group has a lot of that catalog for us. And 5 minutes was not nearly enough to hear that, but thanks for all the resources that you're going to share with us to go on, and for the for Brittany and Tara, really understanding what's on the radar for our legislators and the governors and the legislature is hugely important as we kind of put together our thinking for recommendations. So thank you.
Thanks, Kate. Yes.
Good afternoon. This is Michael Warren with Maternal and Child Health Bureau. Thank you all for your presentations. And I think it really resonated again with me. We talk a lot in the Bureau about the federal government can't solve all these challenges, and the solutions look different depending on what state you're in and what the environment is there. And I appreciate those themes coming up around framing the frames, particularly around social determinants of health and equity. So thank you for that. Tara, I had one question in particular. You mentioned newborn screening. Could you just say a bit more about what the themes are that are coming up around that?
Absolutely. So thank you for the question. And we have seen several bills, and I can provide a follow-up with the specific states, but that we've seen several states that have moved to cover the recommended panel. So the RUSP, for example, there are you all probably know this very well. Every state covers their newborn screening differently. And there are some states that do not cover all of the recommended screenings, but we've seen several states move in that direction to cover more. SMA, for example, now is on the RUSP, and we saw several states move to cover that. It is more challenging in states to just say, yes, we'll cover it, because the way that the screening is done is different and more complex. And as you all know, who've worked on the state level in this area, getting the labs with the capabilities to be able to do the screening and that process can be complex. So it does take states a different amount of time to be able to actually implement that. So we have, again, seen states last session and this session move towards that. I would say SMA is the one in particular that we've seen some more movement on. And I'm happy to follow up with some more details. The other thing I will add, just screening generally, we talked about children and youth with special health care needs at our meeting in January with maternal and child health fellows. So there were about 30 state legislators there from different states. And children and youth with special health care needs came up as one of their top priorities related to children's health, and screening. So newborn screening, as well as other developmental screenings, are areas that our members are very interested in. And we've seen several states enact legislation or introduce legislation to increase access to certain screening. And again, I can follow up with some specifics following this call.
Thank you.
Sure.
Yes, Dave.
Yep. Hi, Steve Calvin. And Jennifer, thanks for all those presentations. I think we've interacted a few times. Steve Calvin from Minnesota. I was going to ask, what kind of collaboration is happening between Institute for Medicaid Innovation and CMMI? Are they informal and, specifically related to sort of system like care delivery model innovation, and then possibly even payment innovation? Do you have any updates on that?
Yeah, that's a great question, and great to see you and hear you. Although you're very small on my screen, I suspect you're human size in person. So that we maintain really strong relationships with our federal colleagues, including those at CMS and CMMI, meet regularly, monthly or quarterly, with folks at CMMI and CMCS. They have representatives who serve on our advisory committees for all of our projects, including our midwifery-led models of care projects, and doula and perinatal community health worker, and the most recent one that I shared on perinatal and child health best practices and innovative initiatives. So there's this symbiotic relationship, again, to the comment made earlier, that no individual stakeholder or group in the Medicaid space can do this alone. It truly takes everyone all working collectively and rowing in the same direction. We're going to be hosting a Medicaid Maternal Health Policy Summit in September in partnership with the Aspen Institute. And we're going to be bringing together federal colleagues, state Medicaid colleagues, Medicaid health plans, provider groups, advocacy organizations, community-based organizations, people with lived experience, all together around 4 core areas, including maternal mental health, doulas and perinatal community health workers, midwifery-led models of care, and prenatal 3. Within each of those 4 areas, we're going to dive into identifying policy strategies in workforce, payment, data and quality, and health systems, so that we're all collectively coming out with big commitments that we are going to lead, co-lead, sponsor, support, fund, whatever our role and capacity is, so that we are all moving in the same direction in a collective way. We recognize that there's an upcoming presidential election. A lot can change in terms of politics, and we want to ensure that there's stability through those potential transitions, and are coming together as a group, including with CMMI, to make sure that we have a plan going forward to carry this work forward.
Thank you so much. Any other questions? I was wondering when you were just talking about the summit, Jennifer, are you encouraging the state Medicaids to bring in their MCH people to the meeting? Or is it
Yeah,
really
we're-
just focused?
Absolutely.
Okay. All right. Wonderful. Yes, we have one more question here in the room.
Hi, thank you for the presentations. Tara, I was just wondering if you see any themes across the states regarding the momnibus bills. So I do know that there were several states that were pushing for different kinds of momnibus bills. So I'm just curious, have there been any underlying themes? Certainly, I'm sure paid medical leave is probably one of them, but be interested to hear your thoughts and trends.
Yeah, absolutely. Thank you for the question. We know Delaware and New Jersey come to mind as ones that they were really large packages of bills. And workforce was certainly one theme. I'll have to follow up on paid family leave because that is a really interesting area. We've seen some legislation on, some in momnibus bills and then some in just in standalone bills in states. And I'd be happy to follow up with some examples of that and what that looks like across the country. We certainly have seen a focus on racial disparities as well. And I think I mentioned implicit bias training, but there's also some other focus on ensuring that we have good data within those states. And that is what we saw in legislation. So those are kind of top themes that I can think of off the top of my head. But again, I'm happy to follow up with some others, as I know those two states in particular had very robust legislation. And then those themes I'm calling out, we've seen a lot of states have standalone bills or bills that they're not calling momnibus, but they have done a lot of the same types of legislation just in separate packages.
So thank you all so very much. Please join me in thanking this great panel for coming and spending some time with us today. We will be in touch as we move forward because we would love to make sure we stay engaged with you all. So thank you for your time. We know Brittany had to drop off early, but thank you so much, Tara and Jennifer, for hanging out to the end. Thanks.
Thank you for the opportunity. Appreciate it. Have a great day.
Thanks. I know you all can't believe it, but we're actually going to take another short break so we can get ready for public comment. So if you didn't finish your lunch earlier, you now have time to do so. So we will come back together at 1:30 for our public comment period.
Oh, David Kennedy. Oh, we see you and I think we can hear you if you want to begin. Sorry, we were muted, I think, on our end. Thank you for being here.
That's correct. And thank you for having me. And it's my turn. I'm Dr. David Kennedy. I'm the past president of the International Academy of Oral Medicine Toxicology, and that myself and several other authors published a paper about exactly what you're talking about today, infant mortality and maternal mortality. Tresandi in 2005, using CDC data, pointed out that 1 in 5 infants have levels of mercury in their blood as to cause brain damage, neurological impairment, IQ loss. That's a terrible figure, but that's an adult level, and it's not meant to protect babies. It clearly does not. Drosh, in 1994, measured infants that had died and found the amount of mercury in the baby was proportional to the number of silver amalgam fillings in the mother's teeth, brain and kidney and liver. Holmes et al. Show that the amount of mercury coming out in a baby's hair in their first haircut is proportional to the number of fillings in the mother's teeth that contain mercury. They also showed that autistic infants had no mercury in their hair. They're non-excretors. They lack the ability to get rid of mercury from their body. The majority, we identified 2 substances, that fluoride and mercury both harm the infant. The majority of fluoride exposure is either the direct result of reconstituting the baby's formula with fluoridated tap water or significant amounts of fluoride residue in the processed foods, including soy formula. the level exceeds the level known to harm that baby. The discovery of fluoride's neurotoxicity at the lowest levels possible further impugns the widespread exposure to fluoride in drinking water. It's simply not necessary, and the government should stop promoting it now. Women, infant, and children, whose job it is to protect the infant, have steadfastly refused to warn indigent mothers, low-income mothers, of the harm they're doing to their baby by using tap water. They said the reason they won't warn them is because they don't want to impair the program of fluoridation. Their job is to protect the infant, not a flawed program. In 2005, Boyd Haley invented an extraordinarily safe compound, MBMI, that immediately binds and removes mercury from all biological systems. Immediately. All expectant mothers, therefore, should drink purified water and regularly take MBMI to remove heavy metals from their system so it doesn't accumulate at a 4-fold plus in the infant. Despite the FDA warning in 2020 about mercury fillings during pregnancy and children, there have been 50 million new mercury fillings placed annually by the Army, Navy, Air Force, Welfare, Indian Service in indigent mothers. 2 steps that will immediately lower the risk to newborns are a simple pill that protects the woman and her fetus from mercury and several other heavy metals, and stopping the fluoridation program, which will cost nothing because systemic fluoride only harms. There's no evidence that systemic fluoride does anything but harm the human being. Take it out of the water, turning the switch off. Our obligation is to protect the infants, not a misguided policy.
Thank you very much for your comments, and I apologize again in advance to everyone if I have to cut you off. I'm trying to make sure we hit everybody that has signed up today. So again, thank you, Mr. Kennedy, for being on, and I think we were accidentally still muted when we began the public comment period. I did mention I'm going to be keeping everyone to 2 minutes. Just because we have so many people signed up and we want to be sure to hear from everyone. So next, is there a Mulabran Mogos who has joined yet? I'm not seeing him online, so we will move to Emily Price. And if we see you later, we will circle back. Emily?
Hi, everyone. Thank you so much. Thank you. Thank you so much for this opportunity. My name is Emily Price, and I'm the CEO of a nonprofit organization called Healthy Birthday, Inc., founded 15 years ago out of the loss of 5 baby girls to stillbirth or infant death. I'm here representing tens of thousands of families and maternal health professionals who have endured the tragedy of stillbirth in America. We ask that stillbirth, the loss of a baby at 20 weeks or greater during pregnancy, is elevated in conversations related to improving birth outcomes for moms. We often talk about maternal mortality and infant mortality in this country, 2 extremely important and devastating issues that must be addressed, but we often leave out stillbirth. This advisory committee itself is called the Advisory Committee on Infant and Maternal Mortality, but no mention of stillbirth and no committee for stillbirth, which actually claims the lives of more babies each year than infant mortality, and horrible racial disparities persist in stillbirth. Years ago, we thought stillbirths just happened and they couldn't really be prevented. Today, we know that's not true. Research shows that a minimum of 1 in 4 stillbirths can be prevented. And now that we know this, we must do all we can to prevent preventable stillbirths and get more babies here safely. The crisis of stillbirth is gaining more attention in the past year as a ProPublica series on stillbirth is now a finalist for a Pulitzer Prize. There are 2 pieces of stillbirth prevention legislation in Congress and new research published in AJOG and BJOG showing proven positive results of the Count the Kicks stillbirth prevention program. Our organization created Count the Kicks 15 years ago to raise awareness about the importance of paying attention to babies' movements in the 3rd trimester of pregnancy and to speak up to your doctor if you notice a change. The results of the program are so compelling, we must act now. In Iowa, the state where Count the Kicks began, we saw 1% stillbirth rate reduction every 3 months for an entire decade, while the rest of the country remained relatively stagnant. Within that, we witnessed a 39% stillbirth rate reduction among Black women in just 5 years. No other state has seen such a change in stillbirth. Health departments, health systems, A1, AMCHIMP, the National Center for Fatality Review and Prevention, Healthy Start coalitions, MICV programs, health insurance companies, and many, many more have become our key partners in this work and believe in this work. Today, free Count the Kicks stillbirth prevention educational materials, just like these, this is what they look like, are available in half the country totally for free. And the other half, you can get them at very, very low cost, depending on if you have a funder of them in your state. These materials spark the kick counting conversation between patient and provider about how a change in a baby's movements can be a red flag during the third trimester. It's simple, it's easy to understand, with health equity at the center. You can visit countthekicks.org to order this prevention education or to learn more about our proven evidence-based work that saves lives and does not lead to any unnecessary doctor or hospital visits. Instead, it sends the right people in at the right time. Together, we can get more babies here safely and improve outcomes for moms. We know through a white paper that was issued last year that Count the Kicks and noticing a change in your baby's movements can alert moms to things like a placental abruption, a maternal fetal hemorrhage, and other issues that may be causing real issues in pregnancy. So today, our simple ask is to place an increased focus on stillbirth prevention in this conversation, to name it, to talk about it, to put funding behind it when we can, and work together to make it a maternal health tragedy of the past. I know so many of you do this already. I want to commend you so much for the work that you're doing for moms and babies across our country. And thank you so much for your service. And thank you for this time. We really appreciate it.
Thank you so much, Emily. We still have not seen Mulabron Mogos or Andrew Williams. So next in line, as we received it, is Jennifer Kelly. Jennifer Kelly, if you're still on, I believe we gave you the ability to unmute your line on Zoom. Okay, we'll circle back. Jackie Campbell, I believe you're also teed up. If you are able to unmute yourself, we gave you the co-host.
I am, and I thank you. I'm Jackie Campbell from Johns Hopkins University School of Nursing, and I also commend the committee for all of your work. I've been listening these past 2 days, and it's indeed impressive. I want to circle back to the issue of intimate partner violence because of the increase in the past 2 years of intimate partner homicide, both during pregnancy and outside of pregnancy. And we know all too well that this is associated with intimate partner violence, and that we need to do a better job of helping our providers assess for intimate partner violence, especially in the fourth trimester. And I've been very pleased with hearing about this attention to the fourth trimester and mental health issues there. I want to be sure that intimate partner violence is part of those mental health packages, the packages that address these issues. And those assessments need to be culturally appropriate, especially for our Indigenous and Black women, and also immigrant and refugee women. The other thing I just want to mention is that in the intimate partner violence field, we are thinking a lot about the notion of safe staying. Pregnant women want to stay with this partner. They want the partner to learn to do differently. And thus far, the interventions have been for abusive people, partners who are abusive, has been centered in the criminal justice system. You have to be arrested and court mandated to do it. And the pregnant women that I talk to want to stay with this person. They want him to get interventions. And if we think about interventions in a behavioral health kind of process, interventions for people who use violence, whether it's toward partners or otherwise, that are part of our federally qualified healthcare services, that are part of the services that the Indian Health Service provides, so that women can stay in an abusive relationship and the relationship become non-abusive. So it's not harmful to her nor to the babies. And one of the things that we think about is that now with homicide, such a big problem, and also gun deaths to children, that one of the things that moms should go home from the hospital with is gun locks. You know, that this is the kind of prevention strategy that can help both the moms, and if there's a horrible situation where he goes for a gun to kill her, so that it's at least locked up, so he has to think about how to get it unlocked, and also for the safety of the babies as they grow. So again, thank you for the time, and let's not forget that this is increasingly a cause of death for women, both when they're pregnant and in the postpartum period.
Thank you so much, Jackie. Good to see you again, and thank you for your comments to the committee. We believe Jennifer Kelly may be trying to be hooked up to Zoom, her audio. I apologize, Jennifer, I know you were trying to unmute. We'll try again. Looks like it's trying to connect. Jennifer Kelly, I see you are trying to connect. Fortunately, we aren't having success, it looks like, in connecting your audio. We can also offer the option to submit your comments in writing, Jennifer. So I think we have a way to contact you from your registration. So we will follow up with you to be able to get your comments to the committee in writing. And perhaps you could join the next meeting to do oral comments. Any reactions or questions from the committee members before we move on from the public comment period? Okay, well, thank you again to all of those that were able to speak today, and Jennifer will follow up with you.
Thank you, Vanessa, and thank you all for all of your public comments. We're going to continue on our agenda now and go to next steps and assignments. Now I'll ask if you all will pull up one slide from our earlier conversation and thinking about priorities and how do we move forward. Pull together one slide, hopefully that it will depict what we've just talked about. And so if we look at it and we look at this slide and thinking overarching, we'll be looking at impactful opportunities related to, you know, following these areas and beyond. But specifically the three focus areas, one would be around the rural health focus, which it includes the things like the residence and loan repayment program, levels of care, deserts, hospital closures. I think the national core, what was the one that you mentioned? Thank you, National Health Service Corps, all would be part of that area. The second area would be more on the social drivers of health, including determinants of health. We can narrow down the focus to a specific area. We can look at, you know, what some of the other states are doing around with their Medicaid waivers and other areas. And then the third focus would be around preconception, reproductive justice. Fourth trimester will be part of this this area as well. So as a committee, are you all good with these three specific areas, realizing overarching our initial focus is where are there opportunities, where are those bright spots that are already in place? And what is missing if you're not good with these three? Yes, Marie.
I just wanted to clarify, is this with the focus of Black maternal health
That is
and infant
correct.
health? Okay,
That is correct. Thank you for bringing that up. It's in my notes. It just didn't make the slide.
And yes, I'm okay with the 3 overarching points.
And it would be Black maternal and infant health. Yes. Microphone.
That's, oh, sorry.
Thanks. Mhm.
So Belinda, would one of these points be the Black maternal health, or this would refer to all of them?
This would be part of the overarching, but feel free to chime in if you're thinking differently. So I was thinking that overarching would be impactful opportunities and specifically impacting opportunities related to Black infant and maternal mortality or health. And then within those overarching areas, we would also be looking at rural health, social drivers of health, reproductive justice, preconception, 4th trimester.
Okay.
So the overarching areas, the focus would be on where we seeing improvements in the country or in communities around Black infant and maternal health.
Okay. Just another perspective. And as I was hearing it, I was thinking that the overarching impactful opportunities applies to Black maternal health, right? And there's, social drivers of health and SDOH in that, but that would be sort of one, and that rural health would actually, the rural health issues and the systems of care thing wouldn't necessarily be Black maternal health focused, but would be rural
So
health,
you're
more
thinking
rural
that
health
the
focused, more
overarching-
systems of care, but it's still impactful opportunity, right? For rural health improvement. I just thought of that as a separate thing
Yeah.
from the Black.
I just want to make sure I'm clear. So you're thinking of it as 4 priority areas versus 3.
Yes.
Okay.
Under all looking, as we approach them, looking for the impactful opportunities, the things that have worked, and then looking to scale those things in those categories. Yeah.
So instead of so you still see overarching would be impactful opportunities, but you're saying add a 4th bullet that focuses just on Black maternal and infant health.
That's what
Okay,
I was
that-
thinking.
is that what
but I
you were
don't know
thinking?
others
Okay.
heard. That's what I
Let
was
me
thinking.
hear from other committee members, and that includes those that are virtual. Are you all thinking 4 bullets underneath the overarching, or are you thinking as part of overarching that includes Black and infant and maternal health outcomes? Yes, Marie.
I
I know we can go either direction.
I think that all 3 of those areas are distinctly related to Black maternal and infant mortality in the United States. There may be programs where the Black population may not be as significant, but could still be amplified to reach that particular priority population, which is suffering in the United States. So I haven't looked at all of the recommendations historically, but I suspect that there may have been already some recommendations just in general on Black maternal and infant health, like in general. So in the spirit of trying to be generative, I think those 3 areas we've all agreed are potential drivers of change that we can help with impacting. And if we have a focus on what can particularly support the health well-being of birthing individuals and their children, I think that might be a unique take. So I would prefer to keep the 3 categories, highlighting bright spots and overarching programs that we can highlight. But the underlying context is how can these particularly help reduce the morbidity, mortality, and disparity for Black birthing parents and children.
Thank you, Marie. Others? Yes, Phyllis.
I would agree, because I think in any one of those 3 categories, Black maternal and infant health is going to show up. And we know when we look at any of the health disparities data, no matter what the category is, Black folks just do worse. And I think about some of the rural settings in our southern states where Black women are just you know, we know about some of the urban issues, but I think it would be, I like the overarching theme of Black maternal health, and we may find that, you know, there are certain things that work for certain rural populations, but maybe not for Black maternal health or that kind of thing. So I think we have we've created a structure that's going to allow us to look broadly, but also specifically at a particular population, as we did with our most recent report.
Thank you so much, Phyllis. Yes, Steve.
Yep. So I was just going to ask, so this is our one slide of focused priorities?
That is correct.
Okay. Yeah. And I mean, I would just say too, I totally agree and believe we should focus on the racial disparities, particularly for Black mothers and babies. But I also think too, and I'm happy to volunteer for it. And you know, it's really clear that unless we learn to pay for it differently. So I'm happy to keep following the money. The slide I sent earlier today was basically just to say, you know, what is value in healthcare? And value is, you know, the patient's experience and the outcomes, either plus or minus, divided by the cost. And I think that's something I'm looking forward to, maybe in St. Louis or down the road, to just really focus on that area. And I know CMS has some, you know, they used to be called the Healthcare Financing Administration, but CMS, there are experts there too that we could just bring in and say, why is this not working? And we have some examples of how it's not working and some examples of how we could fix it. So I'm totally on board with this, but we need to look at it still through a lens of
the healthcare
how
finance.
is the value. I mean, we want to do all these things, but currently we're hoping for grants, we're hoping for, you know, focuses of various agencies, but we can say, look, there's money in the system. It's not being used well.
Thank you. Others? Anyone virtually? And this includes our ex officios. Don't be shy. Sharonda, we see your hand is up. Sharonda.
Yes, I agree with the focus being on Black parents and birthing parents, based on the recommendation from 2021. In that recommendation letter, it was written that particular consideration should be given to those who are Black, Indigenous, and people of color. So I think in the spirit of let's do a deeper dive into what we've already recommended, I think that should be part of that focus.
Thank you, Sharonda. I'm going to go around the group and make sure I hear from everyone. Is Sherry
One
still
more
on?
comment if you don't mind.
Oh,
And I can.
Kate,
you know,
and
I
then
can-
we'll go to
if you-
Sherry.
you know what, I mean, I think with this, with what I'm hearing from colleagues and that kind of thing, I think we'll go with this theme. I think with the rural health, it will take on you know, since there are areas of rural health, we'll have to look at that aren't necessarily that population. You deal with it. But one of the what's not on that list is the issue raised about data and maternal mortality data. Is that kind of not making it to the final list of working to get better measurement and deciding on uniform outcomes for respectful care and maternal morbidity?
I think data kind of, to me, falls under that overarching. So it really just depends on which area you're looking at.
Okay.
So as everyone is reviewing their area that they select to focus on, I think all of us need to think about, do we have the data needed to move the work forward or to make decisions? And so we can include data in the overarching, but if you feel like we need a separate data group, just remember, we're not the largest group in the world yet. And I'm not trying to spread us so thin that there's like a work group of one. So I just want us to be cautious about that. Okay. And let me go to Sherry and then I'll come back to you, Marie. Sherry, do you want to chime in on anything? I know you're virtual and I want to give you an opportunity to say anything that you would like to say about any of these focus priorities.
Thank you for asking. I agree that in any of the three, it would not be hard. It would be glaringly obvious that disparities that impact Black parents and their babies would rise to the top. So as an overarching consideration, I agree with having a focus on Black parents and babies. And I'm assuming that we will be our area of focus later, so I'll hold that until we get to that part.
Thank you, Sherry and Marie.
I just wanted to make sure I heard correctly. So in these three categories, these would be the work groups essentially. The overarching themes that we would look into and make sure to comment on would be, one, what are some programs that are currently working well within that cadre? Two, the financial and fiscal component, and the relationship of those programs in cost savings and, you know, resources that could be allocated from a federal level or from different departments. And then the third one I heard was data. Is the data sufficient, effective, and reproducible in a way that we could use and interpret effectively? So did I hear that correctly from the group?
I think you heard it well. I think the piece that I hadn't stated earlier was the financial fiscal component, the cost savings piece, but I do think it's an important piece.
Okay.
So thank you for bringing that back to the group. So thank you. Is everyone good with moving forward with this? Realizing that we've got healthcare financing, the value of that, and Steve will continue to help us think through that and figure out, because it really may impact any of these areas in reality. So I think, so thank you, Steve. So our next great opportunity is for us to figure out who wants to lead each of these three groups, because we can't just have work groups out operating on their own. We need at least one person that's willing to convene the group and have a conversation about it to at least begin the discussion. I think we can work with our staff here and others to think through where are there some impactful programs so that we can make that connection. But we will need to know, it would be nice today if we could get 3 people to volunteer to lead the 3 different work groups. But if not today, an email will be going out really quickly there afterwards. But it's so much easier to do it now because we need people to sign up for them. And as I'm saying that, I know our goal is to meet in person in December. We're trying to figure that out. We plan to meet in St. Louis at that time, but we feel like December is a long time away. So our hope is that we'll be able to do a virtual meeting sometime maybe in September. And so it will be nice if the work groups would have at least met once before we come together virtually. And we don't know if we can actually do September. We're gonna, the team is gonna check into it. Vanessa and Sarah, they're gonna check in to see if we can add one more meeting to, you know, to the list. You know, they have a contract, and I'm sure adding this one meeting wasn't part of the original contract, but it does feel like a very long time between June and December. So thoughts, questions, concern? Yes, Kate, with the microphone.
Unless someone else wants to take the lead, I'd be willing to convene the rural health bullet.
You'll take rural health?
The rural health systems.
Right,
bullet.
see how people just volunteer, everyone?
Needing lots of help from people.
And Steve has agreed to help you. I heard that in the room. That come from strong genes. I told you my mother just turned 90. She could still hear well too. Anyone want to take social drivers of health or 4th trimester preconception reproductive justice? Not everybody at once, and make sure the virtual people know that they can just come off of mute and say, I'll take it. Yes, Phyllis. Phyllis wants to work on number 3. So if you take it, Phyllis is willing to be on the committee. She just does not want to lead it. So you have a committee member, and we will get other committee members at some point. We just don't have them yet.
Yeah,
Anyone?
so I
Yes.
will help in the second
Social
bucket, the
driver.
social drivers.
I'm trying to get just the one need, and you're trying to help me to get that. So Marie is willing to help on the social drivers of health.
Yes.
Okay.
And this is Sherry. I'm willing to help on the social drivers of health too.
Wonderful, Sherry and Marie. So as you all are meeting, maybe you can think about being co-leads.
Sherry, I think she got us.
I would also like to help on social drivers of health or the social determinants of health.
Is that you, Sharonda? See,
Yeah.
whenever you can go with tribe chairs, that's not an issue. Thank you, Sharonda. So Sharonda's going to also help on social drivers. Sharonda. So who missed the meeting? So Tara and Jacob, we'll have to get them in. Meanwhile, Phyllis, I will work with you on the preconception reproductive justice fourth trimester. I will not chair it, but I will work with you on that until we get to the next level of agreement, and we will check in with Tara and Jacob and Joy. Am I missing anyone? And all of the ex officio members. I noticed you all got really quiet and then, but we will need you all to help on these work groups. That includes you, Carolyn, and you, Danielle, and anyone else that's out in virtual land. We will need you all to join in with us. And then will give us an opportunity to expand to any of our partners. Any of those national partners that have come and joined, and people like others that are in the room that want to join, but we will need to get started. Okay. All right. Any thoughts, questions, or concerns? I know Vanessa wants to share a few things. Hopefully I didn't share it all before she got to it, but Vanessa wants to share a few things before we adjourn.
I'll keep it really brief since I know we're at time. Just some quick operational updates. Thank you all for the feedback and input on the charter. Just wanted to let you know we're moving forward with that renewal package, and I think we're on track. We should have no problem renewing your committee's charter by September 30th. So as soon as we get more clarity on that final language and things like that, we'll be sure to share it. But I did want to acknowledge and thank everyone who submitted comments and feedback for us to consider. The second thing was membership. As Belinda said, we are still working to get approval of 7 new members. That package is in the process still of being reviewed, but it does have 7 potential new members in there for you. And let's see the last piece. Oh, and we've also been trying to backfill the open ex officio spots. So as you saw, we have USDA now, HUD, we have someone from Department of Labor that we'll be able to introduce, and we're still looking for someone from SAMHSA and a couple other key, I think, departments and optives that you all have been discussing. So we'll be sure to keep working on that. And then, as Belinda said, we'll try to see if we can have a virtual meeting in September, but we definitely have plans for that December meeting in St. Louis. We're tentatively looking at December 4th and 5th. It's a Monday and Tuesday. If you just want to save the dates in your calendar, we'll be sure to obviously circle back after today to be sure that works for the majority. But again, December 4th and 5th in St. Louis, if possible, is what we're looking at. Anything that I missed, Belinda or Sarah, that sort of operational?
I think you covered it well. I think the only thing we're looking at, and Sharonda will be in touch with you for December 4th and 5th. I know at one point, Sharonda, you were a little concerned about what the weather looks like in St. Louis in December. I think we've gotten mixed reports that the sun could be shining and it could be relatively warm. And then we've also heard it could be snow and ice. And so I don't know, at some point we'll have to make a decision and take a chance. And if we find out it is snow and ice, we're going to have to quickly turn it into a virtual meeting because safety will definitely come first. So we will be in touch with you, Sharonda, as hosting us in St. Louis or virtually that day, depending on what is happening as we get a little bit closer to it.
Thanks, Belinda. And that reminds me just to think through the following meetings that we have sort of on the books or in the contract. So after the December meeting, the thinking was to convene again in March, and that would be potentially a virtual. And then following that would be a June meeting like this one, probably here at HRSA. And so that's sort of booking us out for the next year. So December, March, and then June. That's what we're sort of tentatively looking at.
I know June is a busy time of year for those of us that have families and whatnot. So early June or late June tends to be better, just thinking about graduations and other life needs and goals.
You have a life outside of the community?
Thank you, Marie.
Microphone. Yes. So if you will hold December the 4th and 5th for the moment, that would be helpful. And we'll keep our eye on the weather. And we'll also keep our eye on the appointments coming through, because the other thing is, for some unusual reason that the appointments don't make it by December, we'll change that in-person meeting to a later time, because we would like to have our new members meet with us in person with the meeting. And for September, we're looking at 1 day, not 2 days. So we'll be sending out once we confirm we can actually hold it, then we will start looking at a one day virtual meeting in September. So any parting comments by anyone? I know we're a little bit over time. And many of us are trying to get to the airport.
Good job, Vanessa.
And Sarah. I want to make sure that anyone virtually want to come off of mute and say anything. Otherwise, thank you all so very much for your time, your energy, your expertise. It's been a great 2 days, and look forward to seeing you again soon. And look for some emails next week. I'll give you this week. We'll send emails next week. Take care, everyone. Bye-bye. The meeting is officially adjourned.